Okay, ladies and gentlemen, welcome in this webinar by the International Representative Committee of the Royal College of Obstetrics and Gynecology and the Egyptian Society of Gynecology and Obstetrics. This webinar, actually, we have five eminent international speakers, so we are really glad to have them today. I'm actually starting till Professor Salam actually join us again. We have actually with us today Professor Zarko Alfervic and also Professor Vincenzo Verghela and Dr. Sharif Abdel Fattah and Professor Anna David and Professor Timothy Draycott. Joining us from the Egyptian Society of Gynecology and Obstetrics, Professor Muhammad Mumtaz, and of course, Professor Hassan Salam will join us in trying to reconnect again now. This webinar really is about the prevention and management of preterm labor, and really will have different topics, all of them about the preterm labor. I just want to tell you that some of the instructions. You will have the chat and the Q&A, the questions and answer. For the chat, please, this is only for the organizers. So if you want to communicate with the organizers, you can actually write this on the chat. In the Q&A, if you have any questions for the speakers, then please write it in the Q&A. And after each presentation, we'll take 3 questions. And at the end of the presentations, all the panelists will answer the questions. Of course, we'll not be able to answer all the questions, but we'll try to actually satisfy as much as possible of the questions. I will give the word now to my co-chair or moderator, Professor Muhammad Mumtaz, the Vice President of the Egyptian Society of Gynecology and Obstetrics. Professor Mumtaz.
Thank you, Amr. I'd like to welcome all the attendees. We are more than 600 now. And of course, it's very nice to see this actually perfect group of speakers in the field of maternal and fetal medicine. I have the honor to have met all of them before. And actually, I would consider them as good friend, Professor Vincenzo Verghela, Professor Zarko Alfervic, Professor Tim Draycott, Professor Anna David, and of course, my friend for a very long time, Professor Sharif Abdel Fattah. The topic we're going to talk about today is preterm labor. And as you all know, preterm labor is a very, very important topic. And it is the most common cause for perinatal morbidity and mortality. And I know there are many international attendees from all over the world, actually. Some of my students called me from Canada, from the UK, and they will be here today. But it's very important to give a very small brief about the problem of preterm labor in Egypt in particular. Most of the attendees will be from here. The perinatal mortality in Egypt, of course, is relatively high, although there has been an improvement over the past 20 years. This in comparison to the great reduction that has happened in infant mortality, because the late infant mortality, 6 months and above, has been reduced over the past 20 or 30 years a lot, but still the neonatal mortality is very, very high. And the neonatal mortality is mainly caused by prematurity. And the problem, of course, partly because of lack of resources, incubators, ventilators, SCABU units, and so on. And the other is that, of course, many of the patients that are delivered preterm, especially here in Egypt, in tertiary centers, have co-factors apart from prematurity. They already have some kind of medical problem and so on. So they are actually compound problems, not only premature. So actually to talk about today premature labor and how to prevent it and how to treat it is a great opportunity for me to be here, one of the panelists. And I would be very interested to know actually what the speakers would say about this topic. Can you, Amr, please introduce the first speaker and first talk?
Right. The first speaker is Professor Zarko Alfervik. He's going to talk about prevention of preterm birth in high-risk women and why the evidence is so inconsistent. Professor Zarko, can you share the screen, please?
Zarko, please put the audio on first.
Can we wait for a second, if you don't mind? We have Professor Salam. I think he put his screen. Professor
Yes, I'm
Salam
with you.
with us.
Can you see my screen?
Yes.
We
Yes.
made a brief introduction, but you can go also ahead, Dr. Hassan, and give us a very quick
Yes, ladies and gentlemen, welcome to tonight's webinar on prevention and management of preterm labor, which is organized in collaboration between the Egyptian Representative Committee of the Royal College of Obstetricians and Gynaecologists and the Egyptian Society for Obstetricians and Gynaecologists. I want to just remind you the board members of the Egyptian Representative Committee, 4 fellows and 4 members, and also we're working in collaboration with the Liaison Committee of the college, headed by Professor Mohammed Al-Fattah, Professor of Urogynecology in Aberdeen. It is my great honor and pleasure to thank and introduce all the speakers today, world-class speakers. We want to thank them for taking out of their time to share with us their great knowledge and vast experience with us tonight. I want to start by welcoming Professor Timothy Draycott, the Vice President of our College for Clinical Quality. He's, of course, Professor of Obstetrics and Gynecology at Southmead Hospital and the University of Bristol. And we all know him for all his work, but in particular also for developing the prompt training program, which is now successfully implemented in over 45 countries across the world, and which has been recognized for 4 stars for its impact on research excellence framework, and also for receiving the Queen's Anniversary Award in 2014. Thank you, Professor Draycott, and welcome to the webinar. I would like also to welcome and thank Professor Zarko Alferevich, who is Professor of Fetal Maternal Medicine and the head of the Department for Women's and Children's Health and Associate Pro-Vice Chancellor for Clinical Affairs at the University of Liverpool. He is also the coordinating editor of Cochrane Pregnancy and Child Birth Group. We know him through his vast work. He has a high H index of 78, I think. And today he's going to talk to us about the prevention of preterm birth in high-risk women and why is the evidence so inconsistent. I would also like to welcome and thank Professor Anna David, who is Professor and Consultant in Obstetric and Fetal Medicine at University College Hospital in London. She is the Director of the University College London Elizabeth Garrett Anderson Institute. Old people like me remember the Elizabeth Garrett Anderson Hospital in Regent's Park, a hospital built for women, run for women, by women, for the sake of women, which is now located at the University College London. And Professor David is the director of the Institute for Women's Health. She is also a pioneer in maternal gene therapy for UGR and also for brittle bone disease and other diseases and gene therapy. And from the Keystone State of Philadelphia, I would like to, in the United States of America, of course, I would like to welcome Professor Vincenzo Berghella, who is a tenured professor of obstetric gynecology and the director of the Division of Maternal and Fetal Medicine and the Maternal Fetal Medicine Fellowship Program at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. And he's going to talk to us about the cervical length screening for prevention of preterm birth. And from Bristol also, I would like to thank and welcome Professor Dr. Sharif Abdel Fattah. For us in Egypt, he's Professor Tenshams, but in the UK, he's consultant in obstetrics and fetal medicine at Southmead Hospital in Bristol. He's an honorary senior lecturer at the University of Bristol, executive scientific editor for the British Journal of Obstetrics and Gynecology, and also for us, he's the former chair of the UK-Egypt Liaison Committee for the Royal College, and he's also the former lead of the MTI scheme for Egyptian doctors, or international actually doctors. He was responsible for all the doctors from all over the world who want to train in the UK. He's going to talk to us about progesterone for the prevention of preterm birth, and the controversy continues. I would also like to thank my dear colleagues, Professor Mohammed Momtaz, who is, of course, professor and former chair of OBGYN in Cairo University, and currently the vice president of the Egyptian Society for Gynecology and Obstetrics, who is going to moderate this webinar together with our dear friend and colleague, Professor Amr Nouri, the former chair of this committee, the Egyptian Representative Committee of the Royal College, and currently the board member and honorary treasurer of the Egyptian Society of Obstetrics and Gynecology. He is a professor in Cairo University, as I said, and will be moderating with Professor Mumtaz. And finally, I would like to thank Merck for sponsoring this webinar, and also to ask you, please, to post your questions on the Q&A answer section, not on the chat section, for the moderators.
Okay. Okay. Thank you, Professor Salam. I think we can stop sharing, and then we can get to Professor Zarku now.
I will start sharing when
Yes.
Professor Hassan.
Can I stop sharing, Professor Salam, because I think it is. Can we stop sharing Professor Salam's screen?
Yes, Doctor, yes.
And then Professor Zarku share the screen. Great.
Can you see that?
Yes, we can. Yeah.
Oh, great. Okay. So, thank you very much for this kind introduction, and it's real pleasure and privilege to be able to talk to you. Ideally, I would like to do it face to face, but we now live in this odd time, so this will have to do. The challenge for me is to try to tell you something that you don't already know or that you haven't heard. Let me try by start by saying that I'm sure you will all agree that when we talk about preterm birth and prevention of it, that we are really talking about at least 4 different worlds, all of which are present in Egypt, I would argue. I'm sure you will all agree that you do have areas and units where you practice high-income country medicine, particularly in the private sector. Then there are areas in Egypt where you practice, where you have basically facilities that we would call middle-income countries, and also low-income countries, and I would argue also some facilities that are pretty basic. Now, clearly the evidence and interventions and our approach will be quite different in these 4 areas. So the challenge is really how to interpret the evidence and how to make best use of it. One way to approach it is to look at what clinical guidelines do tell us, because in modern medicine of the 21st century, I think you will agree that we all kind of crave these guidelines, and this is the first area particularly very often that we go for. And our college has been in the forefront actually with Green Top guidelines, challenging all of us to try to practice evidence-based obstetrics to the best of our ability. What we have done recently, we have tried to summarize or try to be systematically evaluate what clinical guidelines do tell us when it comes to prevention and management of preterm birth. And this has recently been published in British Journal. And I will just basically want to introduce this to you, not so much as a data, as a concept. And we have been used to systematically reviewing the primary research evidence and meta-analyzing them. And I would argue that the time has come with such an industry of guideline productions that we need to try to do the same with clinical guidelines to minimize the duplication and try to be cost effective, because producing guidelines, evidence-based guidelines, is huge effort and huge endeavor, and we should try to help each other in doing that. So what we try to do is to look for in national or international guidelines that fulfill certain criteria. So we have screened 750 records, identified 49 guidelines from 16 different guideline developers, and essentially with using pre-specified quality criteria. And the evidence and what we have tried to extract the recommendations that most of these high quality, up-to-date guidelines agree on. And unfortunately, there hasn't been that much of an agreement. We have tried to summarize it in screening programs, and majority of guidelines appear to endorse cervical length screening, measurement in high-risk women, and screening and treatment of asymptomatic bacteriuria. When it comes to medications, then there appears to be a majority of guidelines do endorse, and you can see here 4 of them out of 8 that have actually tackled the question of tocolysis. 8 unconditionally recommend tocolysis, 3 conditionally in certain circumstances, and 1 says no. Because 7 out of 8, more than 75% said yes, we call that majority endorsement. So tocolysis up to 48 hours, yes. Magnesium sulfate, yes. Antibiotics for PPROM, yes. Vaginal progesterone with cervix, short cervix, yes. We'll come back to that. And corticosteroids, of course. And when it comes to surgery, interestingly, elective cerclage for more than 3 losses, cerclage for short cervix before 24 weeks in high-risk women, and then transabdominal cerclage after unsuccessful vaginal cerclage. So the key challenge is then what do we do with these guidelines and how do we implement them in our everyday practice? And this is the challenge that we kind of posed ourselves in our in Liverpool, in my hospital where I work. And here you can see our local heroes, Beatles, Klopp, and Mohamed Salah. This is actually, those are the big Liverpudlians and Scousers these days. So I'm sorry for all of you people from Egypt. We have adopted Mohamed Salah, and there is nothing you can do about it. When it comes to in our preterm birth prevention clinic, we see women with a previous preterm birth, with previous ruptured membranes before 34 weeks, women who had a significant cervical surgery, and serial cervical length, and we start serial cervical length scanning from 16 weeks. And we do utilize various prevention treatments: vaginal progesterone, arabine pessary, and cervical cerclage, individualized depending on clinical scenario. And I'm not going to talk more about it because other friends will be and colleagues will be talking about it later. So what I will use here as an example of difficulties that we are facing is this omega fatty acid and preterm birth prevention, which is the area that we struggled with in Liverpool. And let me tell you why we struggled with it. Because there is a good scientific rationale for using omega-3 for the prevention, because essential fatty acid, alpha-linolenic acid, can be converted to biologically active derivatives, and then they are known to minimize inflammatory responses. And most of us would accept that there is a significant inflammatory component to preterm birth. So therefore, the logic of omega-3 reducing the inflammatory responses and therefore having a role in preterm birth prevention was a reasonable hypothesis. There have been fair few clinical trials that have tackled this issue, and here you can see the results, demonstrating that when you pull all of these results together, who are pretty consistently showing the benefit, with two large ones from Olsen in Norway and Makrides in Australia, contributing to basically, in terms of weight, 70% of evidence comes from these two large trials with 2,000 and 1,000 patients, showing 40% risk reduction, which is actually more than vaginal progesterone. So it was very difficult to ignore that, and we basically looked at implementation strategies. We found a fantastic leaflet for healthcare professionals and also for patients that was developed by South Australian Health Medical Research Institute, summarizing the evidence, and we basically start prescribing omega-3 to high-risk women, and also started to develop implementation strategies for omega-3 supplementation for whole region, my region, which is Cheshire Merseyside. Now, we became aware that the team in Adelaide in Australia, Maria Makrides, who actually already did one of the trials contributing to meta-analysis, have actually decided in their wisdom to do another randomized controlled trial, basically proving beyond reasonable doubt that omega-3 supplementation in unselected population is the way to go. And having decided that more evidence is needed, they came up with an even larger study of 5,000 women showing absolutely no difference in omega-3 supplemented population, which is completely at odds with the evidence from Cochrane review published by actually same group. What was even more interesting, that when they stratified the randomized population that was randomized by baseline omega-3 status, in women who were omega-3 deficient before supplementation, there appears to be a significant benefit that you can see. This is a preterm birth rate, early before 34 weeks, nearly 3% in a control, less than 1% in this low risk group. However, in the group that is already adequately supplemented through diet, there appears to be a harm, an increase in the preterm birth. So therefore, if you over supplement, we may be actually causing a harm. And therein lies the cautionary tale for all of us obstetricians who prescribe vitamins, left, right, and center, thinking that we only can do harm or no difference, where in fact, it is quite possible that by forcing women to pay good money for supplementation with vitamins, if they are already adequately supplementing, we may be causing harm. In Liverpool, we had a benefit of large research studies that we did in parallel, and actually then looked at the proportion of women who were inadequately supplemented through diet. And as you can see, in our population of high-risk women that we see in our clinic, who delivered either at term in subsequent pregnancy or had a recurrent preterm birth, we had significantly higher number of women with low omega-3 levels than we would normally expect. What was completely unexpected and confused us, that in a healthy controls, women who had 2 consecutive term births, we had equally low, even higher proportion of women with low omega-3. So that was completely confusing, and we're really struggling to know where do we go from here. At the moment, what we have done, we continue to supplement women who are high risk or who have previous preterm birth, but we certainly have strongly opposed and blocked any attempt to offer omega-3 supplementation to general pregnant population in the region. So what was the take-home message? The take-home message is that one size doesn't fit all, and that there is certainly no magic bullet. Now, what is the way forward? The way forward is to integrate clinical expertise, best research evidence, and patient values into evidence-based medicine. The problem, of course, is where does this evidence come from? So here is, having promised you that I'm not going to be talking about progesterone, I will just a little bit. And I'm not going to steal Sherif's thunder. I'm just going to use progesterone as an example of our struggles with interpreting the evidence. If you put in a PubMed, progesterone preterm birth in meta-analysis, you're going to have 87 results. That was yesterday. 87 meta-analysis of progesterone in a preterm birth, right? And here is an example. One of them, published in 2017, talks about vaginal progesterone for asymptomatic women between gestation and sonographic short cervix, showing or claiming a definitive benefit of progesterone in twins. There is going to be there is another individual patient data analysis, like the one published in 2017, that has already reported preliminary results, and full paper is going to come within the next couple of months, and it's called EPIC, and I urge you to read it, telling us that there is no evidence of benefit in unselected multifetal pregnancies, and for twins in short cervix, that the evidence is limited, and therefore progesterone in twins with short cervix should be restricted to research studies, which is at odds with meta-analysis published in 2017. So how this came about? It came about because when EPIC, Individual Patient Data Analysis Consortium, tried to identify the data from 48 studies, only 30 studies provided the data. And for 4 studies, they were unable to trace authors. There was no response for 7 trials, declined participation, and unavailable data. So the question is, who do we trust? In Cochrane Pregnancy and Childbirth, we have decided to tackle this issue of trustworthiness head on. And I want to use this platform and all of you who are listening today to say that this issue is not going to go away. And I'm going to give you here some examples of evidence that needs to be provided in order for us to trust the data. For example, when it comes to research governance, the studies where trustworthiness is questionable is if there is no prospective trial registration for studies published after 2010 without plausible explanations. When authors refuse to provide protocol and ethics approval letter, where they refuse to provide anonymous IPD data with no justifiable reason, and refuse to engage with communication. When characteristics of the study participants are too similar, and this can be tested statistically, when there are implausible numbers, for example, as some recently published work when 500 women with severe cholestasis were recruited in a single center in 12 months, and close to zero loss to follow-up without plausible explanation, because all of you who have done clinical research know that it is virtually impossible to carry out study with zero losses to follow-up. And of course, some implausible results, massive risk reduction, and unexpectedly even numbers of women randomized. So just examples of so-called red flags where we need to dwell deeply into the data and not just take them on face value. So some would argue, unquestionably, and have already argued, that this is sheer scaremongering, that untrustworthy clinical research is very rare, and if this is the case, then such studies are retracted. Some of us have argued that retracted studies and studies that we identify are only the tip of an iceberg, and that we all have a duty and responsibility to look for untrustworthy data and untrustworthy research and to expose it for the benefit of our patients. Thank you very much.
Thank you, Professor Zarko, for this really nice presentation. And I think we can take 3 questions. One of the question is asking, what is Arabin pessary, if you can?
Good question. And I wish I had some slides prepared to show you. I'm not quite sure whether any of my learned colleagues will be talking about it, but Arabin pessary is a silicone plastic device, not dissimilar to pessary that we use for gynecological patients, slightly different, that has been used for preterm birth prevention for short cervix. So it's actually non-invasive sort of cerclage type of thing, I guess. And I would be happy to talk to you about it and our experience with it, which is mixed, maybe some other time.
Okay, we have a question from Dr. Natalia and Dr. Lava, and actually also Dr. Marwa. They are asking, what's the dose of omega-3?
Oh, I'm not going to tell you because then you are going to use it. It's 1,000 milligrams. Yes, and it's not pleasant. Some women report kind of like side effects. They kind of burp with a fishy odor. So it's much better to use fresh salmon if you can afford it. And they're not cheap either. So what I'm saying is I would certainly advise against unjudicious use without further evidence of benefit. And if you are certain that your population is significantly depleted with omega-3 because they don't eat fishy, oily fish and all this sort of business, and also in a high-risk population, then there may be of some value, but I would please do not advocate it for low-risk primates because you can cause more harm than good until more evidence is accrued.
We have a question from Dr. Hoda Al-Fattal and also from Dr. Abir Anab from Jordan. They are asking actually, how would you know the adequacy of it is adequately supplemented? Because we know that if it is adequately supplemented, there is a risk of preterm labor more.
Well, therein lies the problem because doing the blood test of omega-3 is extremely difficult, extremely expensive, and not in the routine, not part of the routine care. We had to send our samples on a dry spot all the way to Australia to be analyzed. So therein lies the problem: is that we do not have a means that we clinicians can assess the vitamin levels in a routine care, so that we can actually have a personalized approach to supplementation, which is urgently needed.
The last question for this presentation, and then we can say it at the end of the discussion.
Zarko, I have a question, please.
Okay.
Zarko.
Yes.
Wouldn't you agree that the problem with trying to find some kind of treatment for prevention, some kind of drug, the problem is that how to identify those who really need it? Because if you decide that low level of omega-3 in the serum is the cause, as you have shown, that it will not really be successful. And maybe it's just something else. I mean, it's not only the low level of omega-3, but those women who are need or in need of omega-3, not just because the low level in the serum, but they really need it for something else.
Well, precisely for that reason, we need to be very careful, and we need to basically ensure that we are only offering interventions for which there is a good evidence of benefit. And I hope that by the end of today's webinar, when we listen to all the presentations, we will be in a position to agree on what to do. And even if we cannot agree on what to do, I sincerely hope that we will be able to agree on what not to do.
Okay, right. I think we can move to the next presentation. Mumtaz, you can actually introduce Professor Vincenzo Bergella.
Professor Vincenzo Bergalla, of course, he is a professor of obstetrics and gynecology, head of the Department of Maternal and Fetal Medicine, and he is actually also the chief editor of the American Journal of Obstetrics and Gynecology and Maternal and Fetal Medicine. And he is, of course, an important figure in the field of maternal fetal medicine in the United States. He's a professor at Thomas Jefferson University in Philadelphia, Pennsylvania. And it's my honor to introduce him to talk to us. He will speak about cervical length screening for prevention of preterm birth. Vincenzo, please.
Sorry. Hi, Dr. Mumtaz. I was muted. Can you see my slides?
Yes, we can see it. Yes.
Okay. Thank you to Zarko for a wonderful introduction to the issues here. My topic today is cervical length screening for prevention of preterm birth. I wish I was there in Alexandria or Cairo or anywhere in Egypt where I've been before, and I hope to go back soon. I'll try, like Zarko, to go over mostly the evidence, the randomized trials, and as I say, meta-analysis. I will talk briefly about primary prevention, but again, my topic is using transvaginal ultrasound cervical length, as you can see in this picture, and the interventions of progesterone, cerclagen, pessary in the different subpopulation, including preterm and labor patients. First, I want to kind of go over what Zarko was going over before. Could there be a magic bullet? I think that there can be. Maybe exercise is really the only magic bullet. There are plenty of data that exercise, moving in pregnancy, safe exercises actually does decrease preterm birth. It talked extensively about omega-3. There's certainly some evidence there. There was a large randomized trial, I hope you saw it in the Lancet, by one of my friends, Matt Hoffman, who was here on the East Coast of the United States, showing baby aspirin in low and middle income countries being beneficial. And there's also a Cochrane about zinc being beneficial. I am not for a magic bullet. I agree with Zarko, but it's in women, and maybe we need to check some of these levels, like from omega-3, maybe we need to look at a subgroup of women, but it's unquestionable that some of these interventions may be beneficial for some women to prevent preterm birth. And maybe the newest slide that I have here is, I don't know if you know, but there are now 5 studies published, including one that came out in JAMA Pediatrics just a couple of days ago, that during the pandemic of COVID-19, preterm birth decreased. Now, I was shocked. I looked at the data at Jefferson, which we published just a couple of days ago, again in the American Journal of Maternal and Fetal Medicine, and we had a 25 to 50% significantly decreased preterm birth incidence, both spontaneous and iatrogenic preterm birth. When I saw this, and I saw this data obviously about a month ago, the data goes from March to July, I'm like, maybe it's just here, but I want to put it out there, see what happens. Sweden, I think, has a couple of reports. Israel has a couple of reports, and all the reports I've seen so far, or at least the majority, I may not have seen everyone, says that during COVID, obviously, some women had COVID-19 infection and were critically ill, a few delivered preterm. But during COVID pandemic per se, most people didn't have COVID, stayed home, changed their life dramatically like we all did. And there was less preterm birth in many nations and in many institutions. And I have a list of whys, which we put in this publication in the pink journal. You can read it yourself. But I hypothesize less stress, anxiety, working from home, no more shift work, no long hours, less physical work. Maybe your partner, your family's around you more. You're able to not go to the cafeteria, have better food, more exercise, which we know certainly helps. Better hygiene, less social interactions, which I hate to say, man, maybe those cause less infections. Many people are postulating that. You can't smoke, you can't use drugs as much. You're not driving and you're not stressed because of traffic. I've been to Cairo and I know in Cairo there is no traffic, so I'm not talking about Egypt. Obviously a joke. The traffic in Cairo was really bad. But now probably there's less traffic in Cairo as well, and less accidents, less pollution, and maybe actually some assistance from the government and maybe some assistance from seeing the doctors less caused some benefit. It's all there to be discussed, but I think if I were a young person, this is one of the most interesting new data on preterm birth, and I think it deserves a lot more research. But I'm a clinician, and so I'll go over what we do, which continues to change. But now we do screen everybody by a transvaginal ultrasound cervical length at the time of the anatomy scan, which here in Philadelphia we do at 20 weeks. 1 to 3% of our patients, and in the literature it stays about the same, have a short cervix of less than 25, and vaginal progesterone, as you know, has been shown to be beneficial. So that's pretty accepted, and Zarko showed some of these international guidelines. In terms of cerclage, we don't know if cerclage on top of progesterone helps more. We published this 3 years ago in the White Journal, and we did see that if shorter cervices, for example, less than 10 millimeters, there was a significant decrease in preterm birth when you added cerclage, the red columns, to no cerclage, the controls. And you can see here the trends for different cutoffs of cervical lengths. We're doing a randomized study on this. We have randomized about 60 now. I wish it was more, but so 50% more. I hope other people will do the same randomized study. So for now, we're not recommending cerclage in these women without a preterm birth, but with a short cervix. But I think there is some data showing that if the cervix is really, really short, less than 10, say, or even less than 15, sometimes the cervix is open even on exam, and they may benefit from cerclage. Question still open. Pessary, here is the pessary. This is very close to the Rabin pessary, basically sits and closes the cervix. Like Zarko said, maybe act as a non-surgical cerclage. There are many randomized studies now, even more than this. And the bottom line, the relative risk here is 0.8, but the confidence interval cross 1. So not recommended yet, not evidence-based yet. I can tell you I was reviewing half an hour before we started today SMFM abstracts that are going to be presented by Zoom, unfortunately, in January, in 3 months. And I saw a huge randomized study from Brazil. I can't tell you the results, but I can tell you that things are not really looking better for pessary the more data comes out. And here it is, the randomized studies that we're doing. Happy if you guys want to collaborate. Dr. Bolig is helping us lead the trial here at Jefferson and other places. So switching, and I wanted to point out to UpToDate, which I collaborate with, that has a lot of this up-to-date stuff because new stuff comes out all the time. New stuff including what kind of progesterone, which again, I won't cover that much, but even in the US where 17P was used more and more, we have more and more data that 17 may not work as well. And so for prior preterm birth, we're doing a randomized study, but if they're out of the randomized studies, a lot of women prefer to be on the vaginal progesterone, start at 16 weeks. Then we do every other week cervical length screening, in these women at high risk because of a prior spontaneous preterm birth. 40% of a short cervix, 25, and we do cerclage. I want to show you the data that I've shown you many, many times. But all the guidelines around the world, again, say that this is evidence-based, and they recommend this so-called ultrasound indicated cerclage based on a short cervix for high-risk women with a spontaneous preterm birth. And we do continue vaginal progesterone, and we stop both cerclage and progesterone at 36 weeks. This, well, I was going to show you transabdominal cerclage. You know, I have flipped screens here, and I'm not going to. But you can do a robotic transabdominal cerclage fairly easily now. We've done quite a few here at Jefferson. And again, Zarko showed before, the guidelines say that if you have failed a transvaginal cerclage before, and the lady is delivered early, say in the second trimester, then we do a non-pregnant transabdominal cerclage. And I know you do some in Egypt as well. I can show you the video if people are interested later. Switching gears, again, more evidence coming out in the gray journal, the green journal, the blue, the white, and the pink journals and other journals, including in twins. And here there's controversy because we do this at Jefferson. We do screen with cervical length, which is the topic I'm covering today. We found that about 20% of our twins have a short cervix using 25 millimeters. And we do give them vaginal progesterone based on this meta-analysis. But Zarko is absolutely correct. This meta-analysis includes a trial which has been under scrutiny, and we're in Egypt, so we should mention that. And I hope the controversy will come to an end eventually, because we did change practice based on that trial. And I hope that we're doing the right thing. It will make sense that progesterone works in these women, but I think we need more evidence. I recently published a study together with colleagues, over 150 plagiarized publications in maternal-fetal medicine and obstetrics, and there are many of those. I found some, we find some all the time as we review trials. So really important, as Zarko say, to publish good science. We're doing a randomized study on women with twins with a short cervix. So again, we give vaginal progesterone if the cervix is a little bit short, less than 25. But if it's less than 15, then we're randomized to cerclage or no cerclage. This is actually going on like 3 continents. If you guys want to participate, Amanda Roman is the lead on this one here at Jefferson. And she did publish a trial in the Gray Journal a couple months ago, which I think is changing practice around the world. She actually started thinking about this about 15 years ago, when I kept saying that cerclage in twins doesn't really work. And again, this was 15 years ago. She put together a large group, as you can see here, of collaborators. It was a really hard trial to do, even if it was a small trial. She randomized women with twins and a cervix of 1 centimeters or more dilated, less than 24 weeks. So again, physical exam indicated cerclage in twins. Here's the characteristics. 17 got cerclage, 13 controls, mostly die twins, some with a preterm birth. You can see here were randomized around 20 weeks, and they were dilated 1 to 3-4 centimeters, about 2 average. And some got amniocentesis, you can see here, many got progesterone. And important stuff on the cerclage side, at the time of the cerclage, they got 48 hours of endomethacin and 1 dose of antibiotics. So it wasn't just cerclage here, the difference was also endomethacin antibiotics. And the impressive here survival curve shows in red the physical exam indicated cerclage did much better, statistically significant, less preterm birth, no matter what the cutoff we looked at compared to the controls. If you have twins who are dilated, which are dilated less than, dilated more than 1 centimeters before 24 weeks, as you can see, more than half deliver right away. You know, they don't carry if you cerclage them, some of them do really well. Here are the actual results. You can see significant really all around. The number needed to treat very, very small for prevention of spontaneous preterm birth at 34, 32, 28, 24 weeks. You gain 6+ more weeks, as you can see here, no matter how we looked at the data. And most impressively, the perinatal mortality went from 77% to 18%, 77% decrease. So really impressive numbers. And these are the neonatal, data. So she concluded a combination of physical examining cerclage, medicine, and antibiotics does prevent preterm birth. Obviously, this was a randomized study of just about 30 patients, so very, very small. But we were told for many years a trial like this could never be done. It was done, and I can tell you many guidelines, including in the States, are changing and recommending this. I wish more data was coming out and more randomized studies were coming out, because I think 30 randomized studies is still a very small number. And on preterm labor, I always talk about this. To conclude, I think that the diagnosis should be made by cervical length, which is much more accurate. Many women coming in with threatened preterm labor, having sac contractions, are actually not in true labor. In fact, as you can see in this slide, 50%, if you do a cervical length, looked nice and closed, more than 30 millimeters. They have a 1 to 2% chance of delivering preterm and can be discharged. We did a randomized study now, many years ago, and showed that using the knowledge of cervical length, you can actually triage your patient much better, admit only those with a short cervix or less than 20, or those with a kind of moderate borderline cervical length of 20-29, but there are positive fetal fibronectin, and this one should be admitted, tocilized, and given steroids, most importantly, while the other ones, most of them can be discharged. In terms of talking about cervical length for prevention of preterm birth, I think we came a long way. I think the one bullet thing, which I put here in the first bullet, it's hard. I mean, more and more things are coming out. I think people should stay healthy, eat fish. Some of them certainly take some aspirin, especially people with risk factors. I put here the pandemic just to make you think about why the pandemic in some countries is decreasing preterm birth, and that needs to be studied. But going back to cervical length, I think women with singleton and no prior spontaneous preterm birth should have vaginal progesterone in the very minority that shorten. The minority that get followed with cervical length and have a singleton with no prior preterm birth, 99% usually have a normal cervix, that can be fine. Very few shorten less than 15, and we're randomizing, but again, I think that cerclage may be entertained if you're not doing a randomized study. In singleton with a prior spontaneous preterm birth, they should be given progesterone. I think Sharifi will go over this, but vaginal progesterone seems to be the way to go. Cerclage in the 40% that shorten less than 25. In twins, again, hopefully vaginal progesterone is working, but more to be discussed later. Cerclage may be beneficial. We don't know really for a short cervix yet, but I think that there is a decent, even if small, randomized study saying that cerclage, if twins dilate on speculum or manual exam, a centimeter or more, seems to be beneficial. And again, I think we should use cervical length screening by transvaginal ultrasound as a first line for diagnosis in preterm labor. So I've seen a lot of change in the world in the last few years, a lot more evidence. I think we've learned a lot. It looks like every day a large randomized study comes out in preterm birth, and we make progress. I want you to stick to the evidence and look at the best evidence published out there. Together we're making progress. Thanks for having me again. It's been a pleasure.
Thank you, Vincenzo. We have a few questions from the audience. Actually, 2 of them or 3 of them are asking, till what age, gestational age, can I do testing for cervical length or cervical dilatation in that sense? And would I be able to do a cerclage at 28 weeks, for example, if I find that the cervix is starting to dilate or very short? I mean, the limit of 24 weeks, is it really a limit, or can it be extended?
So I think it can be extended, but now we should do more research. I think it's an excellent question. I think 95% of the data for both progesterone and cerclage, certainly for cerclage, is less than 24 weeks. So I think clinically, we should stop screening with cervical length at 23 weeks and 6 days. There is some data and more coming out. So I think, again, if I look at the many, I'm sure, young researchers here, that would be an excellent research project, to follow cervical length after 24 weeks, maybe up to 28, even 30. And if it shortens, do randomized studies for progesterone, do randomized study for cerclage, even for pessary. I think that's a great area of research.
I guess so neonatal resources, and there is nothing magic about 24 weeks.
Right.
So in our unit, even when we try to stop scanning serially women at 24 weeks, a lot of them burst into tears. So we actually then do that. We carry on scanning for reassurance and occasionally find dilated membranes asymptomatic at 26 weeks, where you can actually then admit them and sort out in utero transfers and all that sort of stuff. So I guess in Egypt, it's also a question of neonatal facilities. And I would argue that if survival at 25 weeks is possibly zero, given the neonatal facilities, then if you have 40 years old IVF pregnancy first time and you have bulging membranes at 25 weeks, I think that in this particular circumstance, cervical cerclage would be a reasonable option. So I think that there is, particularly in high-risk women, that there is always an element of individualized care.
And there is some data up to 27 weeks that cerclage may work for short cervix. So it's not that there is no data.
Okay,
But
other...
also we need to, but we keep coming back to that there is also a possibility of harm, right? So, if you are basically forcing a baby to stay in hostile uterine environment with inflammatory response, at 24 weeks, I would imagine that that staying in uterus may be almost always beneficial. When you're into 28 weeks territory, then this may not be the case. So the balance is very fine margins where the effective intervention actually may become harmful.
There are 3 other questions, Vincenzo, about rescue cerclage or emergency cerclage, actually with no definition on exactly what do they mean. But I would assume that a woman, like Zarko has said, come at any gestational age with a dilated cervix or a bulging membrane. What's the role of emergency cerclage in these cases, and to what limit would we still offer it to a gestational age?
So we would recommend it. We actually have, that's why, for example, as I say, we screen everybody with a short cervix, but if the cervix gets to be less than 10, 15 millimeters, there's a high chance that if you do a speculum exam or a manual exam, you find them to be dilated, fingertip, 1 centimeter, or even more. And in those women, at less than 24 weeks, we would offer a physical exam indicated cerclage. We have the randomized trial for twins. We have a lot of retrospective and other kind of data for singleton. So if the cervix is dilated, obviously if she's not contracting, obviously if she's not infected, we offer pretty strongly an amniocentesis if they're 2 or more centimeters dilated, less than 24 weeks. They have a high risk of being infected. We do the amnio, most of the time it's negative, and then usually the next morning we would do a cerclage.
My last question is, why not replace vaginal examination with ultrasound? We do already ultrasound to measure the length of the cervix. can't we detect the dilatation that we see on pelvic examination or transvaginal examination by the ultrasound at the same time? Or you do, or you must do also vaginal examination? Actually, this is to explain the difference between what you see and what would you feel. I want you to explain that to the audience, please.
So I don't know who this person is, but I love her or him. I think that's a wonderful, wonderful question. I don't think we should.
This is my question, Vincenzo.
Oh, there you go. Then your wife should be jealous. No, I think I completely agree. In fact, in term labor, there are many studies that you can do an ultrasound, transvaginal, transperineal, and you can actually see the cervix dilatation. You know, obviously you can see progression of labor and angles of progress, all kinds of different things. But for preterm, no question. For preterm, we should also do a transvaginal. I was just discussing in clinic this afternoon, some residents, people come in with rupture of membrane at 30 weeks and they cannot resist putting their ends in. I will cut their fingers off. It would be much better to do a speculum only. And if you want, you could do a transvaginal ultrasound. There is a randomized study, transvaginal ultrasound, no transvaginal ultrasound, no increase in infection in rupture membrane. So I couldn't agree with you more. Prevention of preterm and asymptomatic, management in threatened preterm labor, rupture of membrane, term labor, anytime, transvaginal ultrasound should replace our hands. Completely agree.
In Liverpool, we also have few residents with no fingers. But what I was going to say, what a lot of people don't talk about, particularly in a research setting, is this business of prolapse membranes. And this also needs to be defined more clearly, because there are several types. There are some that are obvious on transvaginal ultrasound, and there is no need to do vaginal examination because actually you can see the bulging membranes beyond external os. But then there are some that a lot of people, when they see cervix of 10 millimeters, I have learned, we don't do that in Liverpool, but then they proceed to do the speculum. And if they actually open the speculum and the membranes are bulging, they call that prolapse membranes. I don't, because in situ, without forced spread of speculum, this to me is still closed cervix. So there is a little bit of a discrepancy. That said, I think that if you put a speculum and then you open it and then you see the bulging membranes, I would say that this is a serious candidate for an emergency cerclage. But actually, this sort of bulging membranes means different things to different people, particularly in the context of us who do transvaginal scanning regularly and routinely in high-risk women, that is.
I completely agree. We should have a classification system, Zarko. We can write the paper after the conference.
Thank you very much, Professor Pergala, for this excellent presentation. Amr, would you introduce our next speaker, please?
Our next speaker is Professor Sharif Abdel Fattah, who is going to talk about progesterone for prevention of preterm birth, and the controversy continues. Sharif is a consultant in obstetrics and fetal medicine in Southmead Hospital, Bristol, UK. He's an honorary senior lecturer at the University of Bristol, and also he's the executive scientific editor of the BJOG, British Journal Obs and Gynae. In addition, he was a former chair of the Egyptian Liaison Steering Group, the UK of the Royal College. Sharif, please. Can you share your screen?
Thank you very much, everyone.
Share your screen, please.
Let me know when you can see my screen, please. Can you see my screen now?
Yes.
Yeah, you can see it, yes.
You can see the screen. Okay, right. Thank you.
Sharif, we are seeing your view, which is the speaker's view.
Yeah,
can you change that?
Okay, let me try something else. Just give me 1 second. I'll try something else. Sorry.
If you just click swap display, you should be able to do that, Sharif.
Sorry, Jarko?
So go back to your slide.
Yes.
Nice photo. Right.
Very nice photo. Go back to your slide. This sort of a previous, you know, what you did before.
Yeah. Okay. I can't do it now. So.
So stop
Hey,
sharing.
you need to go to your screen too.
Right. Okay.
Close.
Stop sharing for a minute until I sort this out.
Yeah.
So maybe we can have a quick question to Sharif. Can we replace dydrogesterone oral in place of the progesterone pessary?
I think we have only Zarko opening his microphone.
Professor Zarko, can we replace dydrogesterone or oral progesterone instead of the vaginal progesterone?
I'm not quite sure why would we try to do that. In individual patient data meta-analysis of all progesterone RCTs, the evidence for oral progesterone is at best promising, but certainly nowhere near investigated enough for this to be recommended. So if the woman completely refuses vaginal progesterone, then I would say not enough evidence.
Okay, thank you.
Okay, can you see my screen now properly?
Okay.
Yes, Sharif, you're okay now.
Okay,
Perfect.
good. Right, thank you. So I'm going to talk about the controversy about the progesterone. And just a quick thing is just, we always use progesterone, talk about progesterone, but how does actually progesterone prevent preterm birth? And these are some mechanisms, some very clever scientific mechanisms. I'm not going to run through them, but just to say that there are plenty of them. It may affect the oxytocin, cytokine, just something else I cannot pronounce, gene, cortisol, cervical So actually lots and lots of possible mechanisms for this progesterone to prevent preterm labor. So why is it controversial then if it is so clever? Because basically these are only theories that are unproven in humans. And if I go back to the same thing, it says proposed mechanisms. So these are all speculations, are all theories, but none of them is 100% confirmed. Another problem is, how do you measure good effect of an intervention on preterm labor? So if we can just think about it for a few seconds, how do you say that this intervention works? Is it because it reduced the preterm delivery, so it improved prolonged the pregnancy? And if this is what we're talking about, what figure? Is it 37 weeks? Is it 34 weeks, 32 weeks, 28 weeks? So even just if we're talking about prolonging the pregnancy, we cannot agree on what cutoff will be the good gestation age. But then does it really matter? Or does it matter about neonatal outcome? So does it matter if the baby is born at 32 or 34 weeks, so long the outcome is good or bad? And what about which neonatal outcome? Is it ventilation, intraventricular hemorrhage, admission to the neonatal unit? But even this, what's wrong if a baby spent 2-3 days in the neonatal unit and then is healthy? So we should look at the long-term neonatal effects. Again, which one of them? There are lots of different things. And one of the problems is that different studies report on different outcomes depending on what they want the result to be. So they can see they are presented as more positive or more negative depending on the agenda by choosing any of these outcomes and choose which one fit what they want to say. Hugely divisive subject, and it ranges from very, very enthusiastic people who believe that it's the best thing in the world to some people believe it's complete rubbish, it doesn't work, it doesn't really help at all. And there will be along the spectrum some people who just look at the evidence. So let's talk about the available evidence, and let's start with the negatives. And of course, the most famous is the Optimum study. So very good, multi-center randomized double-blind trial published in the Lancet. And basically the conclusion is that the vaginal progesterone does not work for any of the possible outcomes. It is not associated with reduced risk of preterm birth. not reduce risk of composite neonatal adverse outcomes, and even no effect on the long-term benefits. But then, of course, it's not the end of the story. So there were some debates. So this debate published in the BJOG a few years ago, following the Optimum study. And the debate was progesterone has no place in the prevention of preterm delivery. And the argument for this is that it's not proven the efficiency, that it is deficient. The past studies that said that progesterone works actually had methodological problems. And this was the first high quality large study for children up to 2 years, and it showed no benefit. Again, question answered. But then there is against. So the criticism, it was randomization start at 22 to 24 weeks, probably too late. And it included women with previous preterm birth but normal cervix. And only 256 women had short cervix. Well, actually, it was much more in other studies. And still, it showed reduced neonatal brain injury. So there was some positive things. And then another study, another meta-analysis. So it was a meta-analysis, updated meta-analysis, including data from the Optimum study of only women with short cervix. And it included the different studies and assessed the risk of bias. And they labeled the Optimum with high risk of bias because of a variety of selection problems. Another big study was called the Progress study, which is about vaginal progesterone in women with previous preterm birth, and looking specifically at preventing neonatal respiratory distress syndrome, and the conclusion that it does not work. However, it said it may identify specific women for whom vaginal progesterone might be of benefit. And this is important, and we'll come back to this later. What about the positives? Very large study, multi-center study, using universal screening. So this is low and high risk women. So they screened everyone, massive numbers, more than 32,000 women. They started screening at about 20 weeks, included 733 women who were identified with short cervix. 465 agreed for randomization of vaginal progesterone versus placebo. And the vaginal progesterone group has significantly lower incidence of preterm labor at all positive gestations and better neonatal outcomes. Another big study about progesterone in women with previous spontaneous preterm birth and short cervix, and they found that, this was comparing the progesterone and cerclage. They found that vaginal progesterone and cerclage both worked very well, and there were no differences. So as you can see here, no differences between progesterone and cerclage. So they are saying that progesterone is as good as cerclage, and of course being less invasive and less surgical risks. Another study talking about the preventing preterm birth and adverse perinatal outcomes in singleton pregnancies with short cervix. And as you can see, good shift and good benefit for the vaginal progesterone. What about other studies, not the sort of very positive or very negative? A study here comparing progesterone, cerclage, and Arabin pessary for preventing preterm birth. And they found that they all worked, but the progesterone was the best intervention. The Cochrane Library, this Cochrane review from 2013 looked at progesterone for women with short cervix and women with past history of spontaneous preterm birth, and they found that it works. So reduction in the risk of preterm birth for the short cervix and reduction in the risk of perinatal death, preterm birth, birth weight, all the possible adverse outcomes. So good review from the Cochrane Library. Okay, so with all this evidence, what should we do? And we all agree on this so far, actually. So Jarko and Vince, we all agree that one size does not fit all. In other words, progesterone will not work for everyone. We have different category of patients. So singleton without prior preterm birth, singletons with prior preterm birth, twins with short cervix. So what about the singleton without prior spontaneous preterm birth, which is basically universal screening? And we just have to remember that more than half of the preterm labor actually occurs in women with no known risk factors. We can think of a long list of risk factors for preterm labor, but in reality, if we think carefully, we find that most women will have preterm birth without identified risk factors, and it will be usually in their first pregnancy. So the reversal screening, as Vince said, it's you do the cervical length at about 20 weeks. if the cervix is short, is longer than 25 millimeter, nothing is required. If it is short, then you consider vaginal progesterone. And what happens in the real world when someone did it? So this large study, again, it was about universal mid-trimester transvaginal cervical length screening, and they found that it did reduce the spontaneous preterm birth, less than 37 and 34 weeks, but not less than 32 weeks. What about women with previous spontaneous preterm birth? So again, if preterm birth already, then you can start the progesterone. If not, then screening, and only consider progesterone when you have evidence of cervical shortening. Twins. Again, this was sort of a fashion a few years ago that all women with multiple pregnancy were given progesterone, but it does not work, and there is no need to do this. So this Cochrane review showing that administration of progesterone, whether intramuscular or vaginal, does not appear to be associated with any benefit in women with multiple pregnancy. Again, another nice study here showing no benefit for using the progesterone just as it is for women with multiple pregnancies. And another Cochrane review saying not associated with any statistically significant differences in multiple pregnancy. Very recent study published in the American Journal, again giving progesterone versus placebo in women with twin pregnancies, and found that this is not beneficial. Twins with short cervix, that's a different story. And of course, this is a higher risk group, and twin pregnancy with confirmed short cervix, there is improvement in all aspects of adverse neonatal outcome. What about women presenting with preterm labor? So far we've been talking about high-risk women and prevention of preterm labor, but what about women presenting already with a preterm labor? Does progesterone work? And the evidence suggests that it does not. So in threatened or established preterm labor, the Cochrane review said that there is no sufficient evidence to say that progesterone actually can work as a tocolytic for these women. Another Cochrane review in 2013, again saying the same, oral progesterone for women presenting following symptoms or signs of threatened preterm labor is uncertain. What about national guidelines? So the national guidelines, our NICE guideline, the National Institute of Health and Care Excellence, says consider either prophylactic progesterone or cervical cerclage for women with spontaneous preterm labor and short cervix. And of course, if you're considering universal screening, so no history of spontaneous preterm birth, but short cervix, you can still consider it. The French College of Gynaecologists and Obstetricians, again, it is recommended that primary prevention preterm delivery in population of women with singleton pregnancies and no history of preterm delivery. So sorry, not recommended, but only if cervical length is short, then you should consider giving the progesterone. Maternal fetal medicine recommendation for the Society of Maternal Fetal Medicine of America. And again, it says multiple pregnancy, no evidence, symptomatics already going in early labor, no evidence, and only for short cervix. And I believe this was initially 20 millimeter, changed later to 25 millimeter. And again, similar to JARCO. So lots and lots of evidence. This was yesterday. So I put in PubMed, progesterone, preterm birth, only papers published 2020, and there are 99 of them. Only in the last 10 months, 99 papers published about progesterone and preterm birth, despite all the evidence, all the Cochrane reviews, all the systematic reviews, all the guidelines, French guidelines, NICE, American, still 99 papers published in the last 10 months in a year when, of course, everything was put on hold, basically. Nothing is happening, but 99 papers published only during the last 9 months. I would just like to finish with this. What is the mechanism or the pathophysiology of preterm labor? So I'm sure we all know this. It's not just one system. It may be cervical insufficiency, it may be uterine overdistension, stress, nutrition, vascular infection, allergic, hormonal, anything. So of course, progesterone will not work for every one of these. Progesterone will not work for everyone. It will work for specific groups, but not for any woman with preterm labor or ruptured membranes or second trimester miscarriage, because it may be caused by other reason other than cervical incompetence. Thank you very much. You're mute, Amr. Amr, you're mute.
Okay. Thank you, Professor Sharif, for this nice presentation. We have actually a few questions here. I think you mentioned one of them about the injectable contraception, but there is one from Dr. Ala Zayat, our friend actually. He's asking, can we give the injectable weekly Proleuton, for example, and or others instead of the suppository if the patient does not actually want to have the vaginal suppository?
Yeah, of course it was studied, but again, I had other studies about which is the best route for progesterone, but I did not want to include it because of the time. And it does not work as well as the vaginal progesterone. It can be used if this is the patient's preference, but again, if the vaginal progesterone is better than the oral and the intramuscular route.
Okay. Well,
there is some reports, Sharif, about some side effects from the injectable, especially in those predisposed for diabetes. I mean,
yeah,
is it true? Do you think that those women who are more or less pre-diabetics should avoid using the injectables?
I have no personal experience in it. We don't use it. We use only the vaginal route, but the evidence suggests that the vaginal is best than the oral and the intramuscular anyway. Yeah,
Vincenzo, I'm sure in the States you had a great experience with the injectable progestin.
Yeah, there are many reports of an association with progesterone and diabetes, but I just wanted to also say that you probably know that, because of the prolonged trial, over 1,700 patients randomized to 17p and vaginal, 17p versus placebo, and showing no evidence of efficacy, the FDA has voted to withdraw the indication for prevention of preterm birth for 17p for the injectable. And now it's up to the company. They only have a few days left to reply, but it may be taken off the market for this indication in the US. That's how far 2003 17p injectables seem to be the best thing in the world, and now it's almost on the but it's based on a very large multinational center sponsored by the makers of the 17p in the US, which was completely negative.
Well, there's another question is when to start the progesterone. Can we start very early during pregnancy, or and till when we should continue the progesterone treatment, and the dose as well, if we give it twice per day or one time per day? So what's your opinion about this, Sharif?
I will tell my experience, and maybe other colleagues can just tell us theirs. But the dose we use is 200 milligrams twice daily vaginally. I know the infertility people, when they use it early in the pregnancy or for recurrent first trimester miscarriage, they use a higher dose, 400 milligrams. But we use 200 milligrams twice daily. And when to start depends on how high risk the patient is. So if someone already high risk and you plan to start the progesterone, then you can start it early. But if it is something that you found during screening, so once you come across the short cervix, then you start the progesterone then. So it depends on the history of the patient and how high risk the patient is. But if you're screening, once you find the short cervix, then you start the progesterone then.
I have a question, Sharif. Would you recommend increasing the dose during pregnancy? I mean, start by some dose and then increase it, say, in the third trimester, or if the woman shows some kind of more shortening of the cervix or some kind of preterm contractions. I mean, would the dose be fixed from the beginning to the end, or you can increase it in certain situations?
Again, I'm not aware of studies that looked at this, but the dose is 200 milligram twice daily. And if it does not work, then probably increasing the dose will not work, because this will reach the concentration sufficient to work.
There is a paper, I think, about using 600 milligrams a day for twins.
It's quite fascinating because, you see, Sharif, we we use 200 milligrams only at night, because most studies have actually, to my knowledge, used 200 milligrams only. And I guess using 200 BD is not unreasonable. I'm not aware of any pharmacokinetic studies, so therefore the dosage is completely open. I'm fascinated by your question about increasing it. And actually, I haven't even thought about it, that when you have progressive cervical shortening, we have actually then, as Vincenzo said, we have kind of jumped into stitch territory rather than going to 400. Maybe we should have done that. I'm not aware of anybody actually doing that, or actually studied it formally to see whether there is an effect. Numbers would have to be large. What I do, I'll be interested in what others have to say. We have tons of patients who we inherit from IVF guys, with all due respect to them, who are on industrial doses of progesterone by any route conceivable, oral, rectal, whatever.
Intramuscular.
So intramuscular, you name it, and on steroids and all sorts of stuff. So, and it's very hard then to persuade them to actually switch to a lower dose, but we say, please, please, please go vaginal. And we, then at 16 weeks, we kind of let IVF guys to do magic, whatever magic they use. But in 16 weeks, we insist on swapping to vaginal route and vaginal route only.
What do you think, Vincenzo, about this kind, the dose of progesterone?
I was telling privately to Zarko, so there are many pharmacokinetic studies. Actually, Dr. Bowley here at Jefferson is doing some as well. We use 200 milligrams, just like him, in the evening vaginally, because I think that the vast majority of the evidence is for that. There are some studies using 400 in twins, but again, I think that the evidence is limited. So we use 200 milligrams, and until large randomized studies and meta-analysis shows us wrong, I think that the evidence is for that. But the pharmacokinetic studies, some are out there, and some more will
Are they kind of dose related? That's what I was referring to.
Yeah, because it doesn't last 24 hours. You can see, I don't have them here, but you can see the graph, and it really only lasts 6 to 12 hours. So it may be that, twice a day it's better, but the randomized study, like you say.
But presumably those pharmacokinetic studies would in the blood, what we are talking about, possibly local effect, and so that's quite
right. She's actually, and obviously some of this is animal data. You need to actually take a sample of the cervix, the uterus, to see the levels there. I completely agree. Probably works more locally.
And just one point about this: there is nothing magic about taking it at night. For those of you who are using single dose, the logic of at night is because kind of it stays. Women, we advise just before going to bed, because then it stays in bed. Because if some of them, if they take single dose in the morning, then it can kind of, without them realizing, it can kind of drop off. So there is no magic in it. It is just pragmatic, because they're going to be horizontal, so it's more likely to stay high up in the vagina, close to cervix. That's the logic of giving it at night, just before they go to bed.
The question is still, till when? I mean, you start at whatever, 16, 20, but
Yeah, well,
which gestation age you continue?
Well, you continue until you don't need it anymore, basically. So
Completely.
you prevent preterm labor. So until you're not worried about preterm labor anymore. So we stop it at 37 weeks. Again, because 37 weeks is enough. But if, for example, you have concerns about neonatal units or absence of facilities, you can keep it for longer. If there are reactions or any side effects, which is very unusual, you can stop it sooner. But basically, it's like any treatment. You stop it when you don't need it anymore.
I completely agree with you, Sheriff, because we used to stop it, kind of worrying about possible safety at 34 weeks. And then we had a cluster of preterm birth at 36 weeks, which basically messed up our stats. And it could have been complete fluke, or it could have been some withdrawal effect. And then we just basically said it makes no sense to stop at 34 weeks. And then end up with a baby in a preterm birth at 36 weeks and in special care baby unit. So like Sharif, we have just then extended it to 37 plus 0. And then this is when we stop.
Yeah.
Maybe the last
completely
question.
anecdotal, but this is why we switched from 34 to 37.
Okay. Maybe the last question in this group, is there any evidence that measuring the progesterone level in blood and then titrating the dose according to this deficiency being available, or what do you think about this? This is from Dr. Latuna. It's
I think this is a question for Vincenzo.
Yeah, probably. Yeah. Again, it's not something we do.
No, and I wouldn't recommend it. Like we said, especially if you use vaginal progesterone, the effect is probably local. So there is limited evidence, and it wouldn't make sense for what we know now to follow levels. So I disagree. I wouldn't do levels at all.
okay. Right. I think we have to move. Professor Mumtaz, please introduce Professor Anna Davids.
Hello, Anna. How are you?
Very well, thank you. Thank you.
Okay. Our next speaker is Professor Anna David. She will speak about, just a minute, I'll check the program. Can you share your screen, please?
Of course, yes.
Okay, Professor Anna David is a professor of obstetrics and gynecology at UCL. She will give us a talk about urinary tract infection and preterm birth. Your slides are on and perfectly seen. Please go on.
Great. Oh, thank you very much. Really pleased to be here. I haven't been to Egypt for many, many years. So I'm very sad not to be able to come over and be with you. But this is a lot of fun. I'm really enjoying. I'm learning lots. So my conflicts of interest are here. I received some funding from Hologic to attend a conference in 2018 who make the fetal fibronectin test, and I provided some data for a prediction of preterm birth study. So I'm going to talk about something a little bit different. Zarko did mention asymptomatic bacteriuria, so thank you, Zarko. I'm going to talk about urinary tract infection and preterm birth, and I hope by the end of the session, we'll have explained to you why urinary tract infection is important for preterm birth, answered the question, or at least given you the evidence to suggest that UTI may cause preterm birth. What do urinary tract infection test results actually mean? There's a lot of change about that coming up. How should we manage urinary tract infection in pregnancy? Does in fact the urinary tract have a microbiome? And a little job for you to do once you're back in work. So I'm going to produce a couple of cautionary tales. The first one I wasn't actually going to talk about, but I thought I would do because it's very relevant for people who are seeing women who've previously had a term delivery. This was a lady who was 30 years old, previous normal vaginal delivery at term, had a normal first trimester midstream urine culture, so that was negative. She had a normal anomaly scan at 20 weeks, and she presented to our day assessment unit with a pressure feeling and increasing vaginal discharge at 21 weeks. And when they did the urine dipstick, she had 2 pluses of white cells, and they did do a speculum and found she had bulging membranes. So what are we going to do? I haven't got the ability to do a poll, but I suspect it might be fairly even who's going to do expectant management and who would place a cervical cerclage. At UCLH, where I work, we don't have a very strong tradition of putting in a cerclage because we have a lot of concern about infection. And in fact, in this particular lady, we admitted her to hospital. We sent an MSU for culture. It showed she had an E. coli. She was treated with oral antibiotics, and she subsequently had a negative repeat MSU. She was discharged at 22 weeks. I followed her up in my preterm birth clinic. Her cervix closed spontaneously, it became long and closed. She had a further UTI with E. coli at 25 weeks treated with antibiotics, and she went on to have a normal vaginal delivery at term, which was fantastic for her and a real lesson for me about managing these ladies. On the other hand, you might be presented with somebody who is an unknown risk, or somebody in her first pregnancy, like this lady, who presented at 20 weeks. Now, she had had a negative midstream urine culture in the first trimester. She went traveling and she was treated for a UTI with antibiotics, but there was no culture sent, so nobody knew what the sensitivities were. And she had no test of cure urine sent afterwards to make sure that the bugs had disappeared. And she came along for her anomaly scan and had an incidental finding of a short cervix at 20 weeks. And because of this concern about urine, we actually sent her urine off again, and that showed she had persistent E. coli. And so we decided not to put in a cerclage. We treated her with antibiotics. She had a positive vaginal fetal fibronectin test at 22 weeks, and she had persistent E. coli. So further antibiotics, despite that, she continued to have this bacteria in her urine, and she was admitted to hospital with bulging membranes. And at 23 plus 4 weeks, she developed a rash and abdominal pain and went into labor. And she's a very lucky lady. She basically had E. coli sepsis. And I'll never forget, this is what it looked like on her hands and on her abdomen. She went on to have a normal vaginal delivery, but sadly, the baby died. She had a major postpartum hemorrhage due to uterine atony, a manual removal of placenta. She developed DIC, so she didn't clot. We had to do balloon compression of a uterus. We narrowly escaped having to do a hysterectomy. She was admitted to ITU and has subsequently done very well. But the issue is she had E. coli, and this is becoming a very dangerous bacteria, because we know, particularly in the UK, about 10% of all E. coli is resistant to standard antibiotic regimens such as cephalosporin. And I did a little search today on the resistance to antibiotics by gram-negative pathogens in Egypt, and came up with this paper by El Kholi published this year, which shows high rates of antimicrobial resistance. So we have to be careful about urine, particularly E. coli, and make sure that if we find it and we identify it, we know that the antibiotic they're on, they're sensitive. So perhaps she had a problem with her kidneys and bladder. But no, she had a normal postnatal renal and bladder ultrasound scan, no urinary tract infections outside pregnancy. In her second pregnancy, her booking first trimester urine was negative. She presented to another hospital. She had elective cervical cerclage at 12 weeks. They were assuming that this was cervical weakness, but then she went on to have another 2 urinary tract infections and subsequently delivered at 29 weeks. Baby did well and she is fine. But I think it's a real sanitary lesson that infection can cause preterm birth. Commonly, we think about it being a sending infection through the vagina. We also know that bloodborne infection can cause it, but urine may well be a problem, and we need to think about it. So the definition of a urinary tract infection is becoming quite complex. NICE, so the National Institute for Healthcare and Care Excellence, define it as significant bacteriuria, so numbers of bacteria over a threshold with characteristic symptoms and signs. And the problem is in pregnancy that women don't necessarily report with frequency or dysuria. They're going to the toilet the whole time, and they often just say, well, this is just normal for me in pregnancy. The gold standard test for diagnosing a UTI during the last 60 years has been to culture an MSU specimen and to identify a pure growth of a known urinary pathogen. And that in itself is a problem, because this definition really comes from way back in the 1950s by Edward Cass, who was a renal physician in Boston. And this is the basis for the original diagnostic criteria. He looked at women who were admitted with severe pyelonephritis to intensive care, and compared with normal controls, he found that this was a significant threshold of 10 to the 5 bacteria colony-forming units per mil. But of course, these criteria should not be applied to patients with simple cystitis or lower urinary tract symptoms, as the test was never validated for that purpose. And so there's still a lot of debate about what is the actual threshold, ranging from potentially 10 to the 2 to 10 to the 6 colony forming units per mil. And I would suggest it's very important to go back to your unit and say, well, what do the microbiologists in your unit feel is an important threshold? Moving on, those studies were done in the 1950s. Perhaps pyelonephritis is no longer a problem. Well, this study, published 18-year retrospective analysis published in 2014, showed that actually acute antepartum pyelonephritis incidence is low, only 0.5%. But even so, those women who do have pyelonephritis have a higher spontaneous preterm birth rate, 10.3% versus 7.9%. But these preterm births are generally occurring late preterm, between 33 and 36 weeks. So does urinary tract infection actually cause preterm birth? So Public Health England updated their recommendations in January 2019, and they do recommend screening for asymptomatic bacteriuria. So they say that persistent colonization of the urinary tract without urinary symptoms occurs in about 4% of pregnant women in the UK, and that if it's not detected and treated early, there's an increased risk of preterm birth and pyelonephritis, and that 20% of pregnant women with an untreated bacteria will develop pyelonephritis. So they recommend screening, and they would suggest that the threshold should be 10 to the 5 colony forming units, but they say you should confirm it in a repeat sample before actually treating the woman. And NICE also recommends sending a urine for culture after treatment, doing what's called a test of cure. Find out, does your unit screen for ASB or does it send a test of cure? And there was a recent study in the UK looking at antenatal units and finding that actually only about 10% of them were sending off a test of cure after treating a woman for a positive urine culture. The Cochrane Library has updated their review in 2019. Antibiotic treatment compared with placebo or no treatment probably, they say, reduces the risk of pyelonephritis, preterm birth incidence, low birth weight babies, and persistent bacteriuria at delivery, but there's inconclusive evidence for reducing serious adverse neonatal outcome. Now, interestingly, many countries do screen for asymptomatic bacteriuria. In the Netherlands, they don't. And so this was a multi-center study with an embedded RCT, essentially looking at whether screening and treating women with asymptomatic bacteria was beneficial. But what they did was they took women who had not had a urinary tract infection in early pregnancy and had no symptoms of a UTI. They did a urine dip slide screen for UTI at 16 to 22 weeks, and then they randomized them to either nitrofurantoin or placebo with a primary endpoint of pyelonephritis or preterm birth less than 34 weeks, and they found no difference. But so it suggests that actually in the low risk woman, in other words, the woman who doesn't have a UTI in the first trimester, actually ASB screening is not benefit. But they didn't include women at an increased risk of preterm birth. And moreover, urine dip slides are not routine or gold standard. So I think we still are not absolutely certain whether screening for ASB is of benefit. The UK is still continuing. I'm not sure what happens in Egypt, but certainly it may be related to the percentage of women who have pyelonephritis, and that may be the best way of deciding whether to screen and treat. In Egypt, this was a small study I found 2017. 2 tertiary centres in Cairo looked at 171 pregnant women, of whom 10% had asymptomatic bacteriuria. So potentially there may be a higher rate of that in Egypt. But I think more importantly, 88% of E. coli and Klebsiella isolates were resistant to cephalexin. So it's very important that this culture is sent off and one actually gets the sensitivities on it. So there are a number of assumptions that I think it's really important to question. And the first one is mixed growth or epithelial cells. And very often I'll talk to a microbiologist and they'll say, oh, she just did contamination, you just need to repeat the sample. Well, NICE does suggest repeating the sample, but only doing it once. I think one of the important things is to guarantee that there is a cold chain, i.e. the urine can go into a fridge and that there's rapid transport to the laboratory, because as I'll show you shortly, if there is no cold chain available and if it takes a long time to get the sample to the lab, then you may get an increased chance of having a mixed growth. And polymicrobial infections can be significant. So there can be an interaction between, for example, group B streptococcus and E. coli. So it may be that mixed growths are actually quite significant. When we looked into that in our preterm birth clinic, we did actually find that having a mixed growth or a non-significant growth, that is less than 10 to the 5 colony forming units per mil, was actually an important factor. So in our study of 1,200 women, in those who had a mixed or non-significant growth, they nevertheless had a higher rate of late preterm birth, a higher chance for having a short cervical length, and they had higher vaginal fetal fibronectin. So it may be that significant bacteriuria is important, even when you have less than 10 to the 5 colony forming units per mil. It is again this adage, you can't have something fitting all. You have to look at the patient in front of you. You can't also attribute symptoms to pregnancy. So pregnant women have lots of urinary symptoms all the time. They're always getting out of bed at 3 o'clock in the morning and can't get to sleep. When we looked at this to see whether there's any change in women who deliver preterm in terms of their symptoms, we didn't find any difference. So 268 pregnant women, we did what's called the Artemis standardized questionnaire. So it asked an awful lot about lower urinary tract symptoms. And we still found that women who delivered at term or preterm still had a very high symptoms score. And so it could be that women who are pregnant simply relate a lot of symptoms which might be completely unrelated to their risk of having a urinary tract infection. And there's an old adage, normal urine is sterile. Well, it's not. Normal urine contains bacteria, and we can use enhanced culture techniques and molecular sequencing to show that. And more importantly, it appears that women who are pregnant are more likely to shed the urothelial, the epithelial lining of the bladder. And we know that bacteria can be associated with these shed urothelial cells. So much of this work has been done outside pregnancy. This is a really nice image of a single cell. So it's a single shed urinary epithelial cell in a patient who has Enterococcus faecalis in their confirmed urinary tract infection. And you can see in each of the planes that these bacteria, these green bacteria, are actually sitting inside the cell. They're not on the outside of the cell, they are inside the cell, which basically means that if you treat a woman for a short period of time with antibiotics, you may well not get rid of these bacteria. And furthermore, you may find that actually concentrating the urine actually gives you a better result. So traditionally, to culture an MSU, they take only 2 microliters of the urine and they rub it over a plate and then they culture it. Well, this study found that if they spun the urine, took the sediment and then cultured that, they were much more likely to identify pathogenic bacteria. This was in women who had chronic lower urinary tract infection, so outside pregnancy. But it may be that we're going to move on to genomic analysis of urine enriched by centrifugation to be able to discriminate between women who actually have a true urinary tract infection and those that don't. And then the other assumption that we all think about, urine dipsticks are good at diagnosing urinary tract infection. Well, they're not. They're widely used in obstetrics to dip the urine to look for proteinuria. But there are meta-analysis of urine dipstick to rule out a urinary tract infection, looking at 10 studies in pregnant women, found they're not very good at ruling it out. So they have a low sensitivity. So essentially the bottom line is, if you think someone has got a urinary tract infection, they may not have any typical symptoms, you should send off an MSU culture and have a look and do a diagnostic test rather than simply a screening dipstick. So what can we do to improve the diagnosis of urinary tract infection? Is there anything that we can do locally? Well, one of the big things is to try and speed up the amount of time it takes to get from the woman to the lab. So this is a study showing that the white cell count deteriorates rapidly over time. If you actually if you look at the length of time taken, and sometimes it takes a urine, 24 hours to get to the lab. If you store it at room temperature, this is the drop-off. If you store it at 4 degrees, this is the drop-off. If you actually get the woman to do the urine into a boric acid tube, which prevents the bacteria from breaking down, then you do actually get a better result. But certainly having used these boric acid tubes, it's difficult to persuade women to actually, first of all, pee into the pot. They usually find it easier to pee into one of the larger pots, and they often tip the boric acid away. One other thing that we tried was we looked at the speed of getting it from the clinic to the lab. And we found in 212 women that if we actually had a speed of less than 3 hours, then there was a much higher rate of a true result. So less mixed growth and more negative growth, whereas more than 6 hours, we had a very high percentage of mixed growth. And remember, the recommendation is that these women should be repeating their test. So this is very costly. And it's important to try to speed up the time it takes to get the sample from the woman to the lab. And importantly, if you train healthcare professionals to teach women how to produce an MSU specimen, it reduces the mixed growth urine results. So we performed a training package for midwives on advising them how to produce an MSU sample. So before and after, we found there was a reduction in the mixed growth after they had done the training package and were therefore actually telling the women how to produce an MSU sample. And then if we're thinking about high-risk women, we've been looking at women in our preterm birth clinic. So these are women who are having a cervical cerclage either because they've had 2 or more previous preterm births, or because they're found to have an ultrasound indicated shortening cervix. And what we found was, if they've had a urinary tract infection in the first trimester, and even if it's treated, when you put in a cerclage, they're more likely to deliver at a lower gestational age of delivery. It didn't matter if they had a UTI after the cerclage, it was the fact that they'd had one before the cerclage. And I suppose it is possible that the UTI was contributing to their shortening cervix, and therefore it was not a weak cervix that they had, but it was actually inflammation related. So I think it's very important, if you are contemplating doing a cervical cerclage in women, actually send off their urine, and we do that routinely on all our ladies who go for a cerclage. Whether to treat them or not, that's a difficult issue. We do treat them. In fact, we give antibiotics at the time of the cerclage, so which often will get rid of it. But it's important to bear it in mind that if they have a UTI in the first trimester before the cerclage, they may well deliver more preterm than those who don't. So pregnancy has a high risk for urinary tract infection. It's associated with pyelonephritis and low birth weight. Treating it may reduce the risk of preterm birth. UTI in early pregnancy increases the risk of preterm birth after cervical cerclage. Suspect a UTI. Women don't necessarily have typical symptoms. Send off the urine. Don't rely on dipsticks. Beware a mixed growth, beware non-significant growth, and send a test of cure MSU after treating a UTI at least 72 hours after the last antibiotics. And when you go back to work, I think it's really helpful to know what your local threshold of bacterial count to diagnose a UTI is. Does your hospital give information to guide women about how to produce a sample? Which pots do you use? Are they the really narrow ones, which are very difficult to pass urine into, or are they the wide ones, which make it easier? How quickly do your MSUs get transported to the lab, and what is your cold chain? Do you have a fridge, for instance? How does your hospital report the culture results? And does your hospital ask women to do a test of cure? So, and I would say, talk to your friendly microbiologist. I've always found them incredibly helpful when I phone up and ask for advice. And just like to say thank you very much for the whole team who've helped me with this, and very happy to take some questions.
Mumtaz.
Yes. Thank you very much, Professor David. I think we have a couple of questions. The first question is, if you start using an antibiotic and then the woman has some kind of recurrent urinary tract infection in the same pregnancy, would you give some kind of long-term prophylactic antibiotic therapy till term? Would this be actually a proper way to manage these patients?
To be honest, the evidence is not there. It is almost a weekly occurrence that I phone up on my friendly microbiologist and ask them exactly this point. I think it very much comes down to how much access you have to sending off a culture. They would prefer to do what's called an enhanced culture. So we would send off the urine again. We make sure that it gets to the lab very quickly. We highlight to the microbiologist, and they do a longer culture and specifically look to see whether this is the same bacteria that they had before. And in many ways, we prefer to simply give antibiotics for longer, rather than to give them a low dose of prophylactic antibiotics, which may end up giving the woman, a bacteria that's resistant to many of the antibiotics that we have.
There is another question from Dr. Abir Annab. She's from Amman, Jordan. Do you treat Staph aureus infection in urine? And do you check for coagulase positive strain during pregnancy?
So we do, if we think that the culture has been, that the urine has been produced in the right way, then we do, although with a staff, we'd probably be more likely to culture it again, depending on the background of the woman. So if it's somebody who's low risk, I would send the urine off again to confirm it. If it's somebody who's high risk, I probably would treat it.
Okay, last question is actually about the presence of vaginal colonization or cervical colonization. The woman with recurrent urinary tract infection, would you do a high vaginal swab or cervical culture to exclude a source of infection from the vagina or the cervix?
Well, for women in our preterm birth clinic, we do actually send off a perineal swab for group B strep, and also a swab for bacterial vaginosis in our clinic. So we do know whether they have had, whether they've got group B strep. But we wouldn't routinely, if they've got an E. coli in their urine, we wouldn't routinely send off a high vaginal swab. We don't pick up E. coli in the vagina very often.
Thank you very much, Professor David.
Professor,
Our last speaker,
Professor
Salam, please.
Yes, there is a question from Professor Bergella about about the colony count depending on the type of bacteria. For example, some suggest any colony count for GPS.
What's significant? You mean which is the significant?
Instead of using 10 to the 5th, you know, for everything, it depends sometimes on the bacteria. If you have good B strep at 10 to the 2, like here, they want us to treat. If depends on the bacteria, you know, before they say stuff.
It would certainly for group B strep, we would probably, if it was a low bacterial count in the urine, we'd probably just, you know, do a perineal swab and check to see, is it coming from the perineum, is it contamination, rather than a true culture. I mean, we don't actually get a report anything less than 10 to the 3. They only report 10 to the 3 or above. 10 to the 3, 10 to the 4, 10 to the 5. As I said, it depends where you work. It sounds like you're on a hospital where you just get the number. I wish I did.
We do.
You're very lucky.
Great lecture.
Thank you, Professor David. Excellent presentation. We have to move on because I think we have to finish at 11:45. So our next speaker is Professor Timothy Draycott. He is Professor of Obstetrics and Gynecology at Bristol. He's the Vice President of the Royal College, and he's a great friend. Timothy, are you with us? Tim?
Yes, I'm here. I need.
Can you share your screen, please?
Booster bees need.
Actually, Tim was in Egypt before, and I was asking him what was the best experience that he had in Egypt, and he said was eating koshari. Right, Tim?
No question. Absolutely. Koshari Kamela. That's me.
Okay.
Booster bees need to stop sharing their screen, and I will share mine.
Can I ask the organizers company to stop sharing their screen, please?
Perfect. That'd be perfect. Thank you very much. Yeah, Mohammed, absolutely fantastic to be here. I'm going to. I'm not as clever as everyone else, so I'm going to talk about how do we do all the things that everyone's been talking about today. And Professor Salam very kindly gave me just a very short section at the end here to talk about what I think is going to be the challenge for maternity care of the next decade is how do we personalize maternity care? I think it's common ground from all the speakers that we need to do the right thing for the right woman. And I'm speaking on behalf of quite a big team at the Tommy's National Centre for Maternity Improvement, developing this. Now, I think, as I said, I think we need to move away from population-level care to women-centered care. And I think women deserve the right care at the right time. And one of our problems we have in today is some women get too much too soon, some women too little too late. Let's try and focus our care on those women who need maternity care, obstetric care the most, and we can therefore get the best outcomes for them. And I think one of the problems is, and it's been really beautifully illustrated tonight, that there's endless data, but very little help to apply it. And one of the things I always talk about on the prompt stuff and everything else is how do we make the right way the easy way? How can we improve risk assessment? How can we support best care, including continuity of care? And how do we provide clinical decision support at the right time for the right woman? So the Centre for Maternity Improvement was funded recently by Tommy's, a big charity in the UK. It's a collaboration hosted by the Royal College of Midwives and the Royal College of Obstetricians and Gynaecologists. And we've just produced the first version of the app to personalize care using Fetal Medicine Foundation and also some algorithms from Andy Shannon to risk assess women for preeclampsia and preterm labor at booking. We will aim to de-escalate care for low-risk women, so they'll be seen by midwives in the UK, but increase care for high-risk women and really focus on continuation care. Our ambition is to reduce stillbirths by 600 a year, and our ambition is to reduce preterm births by less than 32 weeks by 1,400 a year here in the UK. Now, I'm just going to really whip through how this might work. And this app has just been developed and will go through evaluation and implementation. If it works, then I think we'd be very keen to have a think about how do we share this with people, across the world. Okay, everybody knows all the risks for preterm birth. Nulliparous. If you've had one preterm birth, two preterm births, ethnic differences, do you smoke, everything else, and we all know all of these things. But how do we put them into one place where we can actually easily calculate a risk for women? And of course, all of us these days, carry a computer in our pocket called a mobile phone. So can we use a mobile phone to help women, risk assess them in a proper and accurate way? Now, we're going to use the same technology as the QIP app. Andy Shannon's app is based on to risk assess women at booking. And if you want to, Andy's app already exists. It was developed for high risk women rather than population level. It's available for both Android and Apple and is free at the moment. I absolutely recommend you download it for both risk assessment and also care during labor, suspected preterm labor. Now, continuity of care is really, really important. And we need to work out, okay, yes, we need to do preterm birth clinics. Yes, we need to do other elements of care and all the things we've discussed today, progesterone, cerclage, MSUs, everything else. But actually continuity of care is probably just as important, and particularly important in the UK for Black and minority ethnic women. Decision support. Okay, there are hundreds of guidelines. JARCO did a review of reviews and guidelines. That just shows how many there are. One of the problems we have is how do we take all this information and put it into the right place so we can actually provide the right care for women? And we will be providing decision support for reduced fetal movements and suspected preterm birth. So the app that actually exists today, we've just developed it and we're starting to test it now, is going to help us by risk assessing women at booking, then providing a continuity. The woman can have the app, the hospital computer system will also have the same information, and we will be able to then risk assess women, de-escalate care for low-risk women, and escalate care for high-risk women. Plus, each time they come into hospital with, let's say reduced fetal movements or suspected preterm birth, then we will be able to reassess their risk, knowing all their background history. Now, I won't go into the detail of what actual interventions we're going to use, except to say that we'll be completely consistent with UK guidance. Very high-risk women are going to be referred to a specialised preterm birth clinic. Medium-risk women are going to have a slightly different care pathway with more surveillance, and low-risk women are going to be de-escalating their care back to their community midwife. At the same time, we'll be looking at placental dysfunction. High-risk women will be given aspirin and have a series of scans, as you'd expect. Medium-risk women, less scans, and low-risk women, no scans. And we think by doing this, we can identify the same 70–80% of women with poor outcomes that we currently do in 50% of the population. We can identify the same proportion of poor outcomes in 10% of the population. So we can de-escalate care for 40% of women. Now, I'll have to show you how the app works, but each time it will work out. So for example, if you are at risk of placental dysfunction, it will give you a different set of decision supports for reduced fetal movements than if you're completely low risk for placental dysfunction. Similarly for threatened preterm birth, and this is the QIP app, which I'm sure many of you know, which we use absolutely routinely in our service, as Sharif knows, for women who present with suspected preterm birth. And it's a really accurate way that you can demonstrate to women. You fill in the form on the left-hand side on the app, and you get the results on the right-hand side after putting in the cervical length or fetal fibronectin. You can use either. And we would admit people with more than a 5% risk of delivery in the next week, and we'd let people go home with less risk than that. Now, of course, it's not so important by the time you get to full term, just as Sharif and Jarko were discussing, by the time you get to full term, 37 weeks, well, the risk of preterm birth has clearly gone away. However, if you're at risk of placental dysfunction, then there's still a really important discussion to be had about should you be induced, should you not be induced, what's the best care for women. Now, we're just about to move into the implementation phase where we are rolling this out in 4 units across the UK. We're then hoping to scale it up to 20 units and then look to a much bigger rollout in the next few months. Now, there is a very technical discussion about how we're going to use it, how do we help women and staff members to use it. But I think if you look at what's happened with hypertension apps in the UK, for example, absolutely now in standard use in many units because of the COVID crisis. And I think we're going to have, hopefully, a similar kind of impact. So my conclusion is, I think for everything we've heard today, what I've learned today is how much information there is about preterm birth. And what I need help with in my practice is how do we harness all those data to provide the right care for women? And I think we can do that using algorithms and essentially using apps on your phone. And I think that will help us avoid overtreatment. I think it will enable us to give the best care to optimize outcomes. Clearly, this system needs to be both implemented and evaluated. But if it is successful, if it does what we think it can do, and there are good data from St. George's, that certainly applying the Fetal Medicine Foundation algorithm can reduce the risk of preeclampsia. If we can do the same thing for placental dysfunction more generally and preterm birth, I think that would really help us provide the best possible care. I'm just going to finish with what I would love to show you all in normal times. This is our new college. This is your new college, is my new college, is all of our new college. And I think although a lot of us felt very close to the old college. We did our exams there, we did everything else. The new college, I think, is going to be fantastic. And if only I could take you all there, I'll show you around. And hopefully when COVID settles at some point soon, I would love to host any of you at the ERC-RCOG and take you around our new building, which it opened just before COVID. It looked fantastic and it's been closed ever since. But thank you very much for tonight.
Thank you very much, Tim. I would ask you, I mean, this application would identify those risks, but can it be extended to identify the best method of management for every patient? I mean, it would be ideal to say that this patient is at risk of preterm labor, but also from the score or from the questions that we ask her and from the measurement of the cervix, then, for example, she should take progesterone or she should do a cerclage. Do you think that this is possible? I mean, individualized treatment in the same concept.
If we could agree on what the best care for individual level women was, then we can definitely do that. But that is a challenge. And I think that is a challenge. Look at Sharif. Sharif and Jarko both produced a slide, a PubMed slide. Here are 90 studies this year on progesterone. Okay, now for that's fine if you're as clever as Sharif and Jarko and you read all those studies every day. But it's much less fine for those of us with busy clinical practices. I mean, Sharif's busy, don't get me wrong. I work in the same unit. We need help to do the right thing. Now, we could certainly attach national guidance to that app to help people do the right thing. Whether or not we can personalize care down to an individual level, that's an ambition we're working towards.
Sorry, Mohammed, can just answer your point again from a different point of view. The main benefit of the app is not only to identify the high-risk women and then, as you said, hopefully tell us what to do. The main benefit is to identify the low-risk women.
Yeah.
To avoid intervention that are not necessary. So for women, so on the QUIP app, there are two lines, either women, symptomatic women or asymptomatic women, and that's common. A woman coming with a bit of pain, you don't know whether it's preterm labor, you admit to hospital, you give steroids, depending on neonatal facilities, you may transfer care to another hospital. And the purpose of the app is to identify the woman who is at low risk, so you don't have to do all this. And again, for the asymptomatic women, so the women with high risk who we follow in our preterm labor clinics, we use the app to identify the low risk women where we can be more confident with the frequency of the transvaginal scans, or do we need to give progesterone or not. So it's actually, the main benefit is to identify the low risk women who do not need the intervention, so you can avoid unnecessary intervention.
It's actually both.
Okay, actually, I have a couple of questions for all the speakers. I think they have been asked in the questions, but not to a specific speaker. What's the role of bed rest? What's the role of aspirin? What's the role of more or less limiting activity, avoiding intercourse in prevention of preterm labor, or to those women who are already having a cerclage or progesterone? So I think if, starting by Zarko, for example, we can answer these points and listen to the different points of view from all the speakers.
Bed rest, it's very good for DVT.
Dangerous.
I'm not quite sure.
Can you elaborate on that, please?
Yeah, I'm not quite sure about preterm birth. I'll leave it to that. Aspirin is fascinating. There's been a phenomenal randomized control trial recently of low-dose aspirin showing reduction in preterm birth. Unfortunately, they were unable to differentiate between spontaneous and iatrogenic. So it is, I've tried to kind of clarify in my mind whether the benefit comes solely for what is known to be a reduction in kind of preeclampsia and therefore delivering a preterm delivery related to kind of maternal condition or spontaneous preterm birth. So that is yet to be elucidated, I guess. That was, as far as I can remember, that was a low-dose aspirin in actually low and middle income countries given to everybody. So I think the jury on aspirin is for low risk women is still out, but at least when it comes to spontaneous preterm labor. And people have argued that for primates, if you can't afford fantastic FMF algorithm, then low-dose aspirin for everybody, for all nulliparous women, could be the way forward. And this latest randomized control seems to endorse that. But that is something that is going to run and run. And so that was aspirin and bed rest. I think I will leave others to answer the rest. Or tell
Professor
me,
David, a comment?
Yeah, I would very much agree with Zarko about the bed rest. I think it's really interesting to remember that there is quite a lot of substantial evidence looking at standing up for long periods of time and the risk of preterm birth. And I think, I really liked Vincenzo's response on why it is that potentially during lockdown, there appears to be a reduced risk of preterm birth. But we know that if you stand up for long periods of time, factory workers or people who are cleaners in hotels or sitting, having to stand up on checkouts, they have a population, they have a higher risk of preterm birth. And I think on an individual basis, I've certainly admitted women with a 2 millimeter long cervix because they're running around with a toddler at home and they don't have an opportunity to rest, stuck them in a bed and managed to get another, 6, 7, 8 weeks out of them, which they may not have been able to get if they'd been at home. But I'm not an advocate for telling somebody to sit at home in bed because I don't think there is any evidence. I think it'd be really nice to do a study to see whether that actually is of benefit. I can't remember what else there was. I think you asked about
Aspirin.
Aspirin. Yeah, I mean, I tried to take a very detailed history to find out why it is that, whether there's anything else going on. And if you look at placental insufficiency, there is a crossover. You look at the placenta, women who deliver preterm, you may well find that a proportion of them actually have evidence of maternal venous malperfusion or fetal infarcts, that side infarcts, that kind of thing. So there does appear to be quite a bit of crossover. And so sometimes you don't know exactly why they went into labour preterm. It's not obvious. And it may be that putting them on low dose aspirin is beneficial. But routinely giving everybody who's had a previous preterm birth low dose aspirin may not be the right thing to do. Again, it comes down to, picking your patient in front of you.
I would just like to endorse what I was saying that high activity is not, there is no, bed rest is not opposite of saying women advising against high activity. What we are talking about here, bed rest as a medical intervention, because when you look at the studies that have investigated bed rest, you're talking about 23 out of 24 hours in bed and basically just going out of bed only to empty the bladder and stuff like that. That I assume we are talking about bed rest. What Anna is talking is common sense, and completely agree that we have all seen advised against excessive physical activity, prolonged upright standing, and all that sort of stuff.
Can I add, what about asking patients to avoid ejaculation in the vagina? I mean, either ejaculation.
Actually, avoiding intercourse.
Condom. No, I mean even just mainly for the semen, because we know that there is prostaglandin, and also maybe asking the patient to avoid nipple stimulation, for example. Do you recommend this for patients at risk of preterm labor, or you don't mention this at all? This is for the audience as well.
Maybe I can chime in a little bit. I published on this in the Great Journal. I remember when I looked at the data, I was looking at bacterial vaginosis at preterm birth, but it was NIH, National History of Health data. And I found that actually up to 6 times a week intercourse was associated with that decreased incidence of preterm birth. So when I looked at the data, I'm like, I did the analysis wrong. This is terrible. Klebanov, who is one of the leader pediatricians, in the States for many years, told me, no, don't be fool. People who exercise, who have sex, etc., are the healthiest people. So when you look at the data, you need to think about that. Is there a confounding bias that, again, if you're healthy, you're going to be more active and you're going to have more sex? Saying that is to say that the evidence that we have is that bed rest, decreased activity, in fact, increases preterm birth, and there is evidence for that. For short cervix, there is also NIH data. If you have a short cervix and you place an activity restriction, the preterm birth increases. I agree that we should be aware of the extremes. If people have shift works, I completely agree with Hannah. People work too much, stand too much, etc. But in general, exercise and sexual activities are not harmful.
Professor Al-Fattah, do you have a comment?
Yeah, I agree. Again, it's good for mental health just to be as normal as possible. And when you start telling people not to do lots of things, it has a negative effect. So unless the patient is symptomatic or there is definite confirmation of short cervix, for example, then there is no need to avoid intercourse. As Vinny said, it's just like any other activity, and it's good for mental health and just to be as normal as possible. So without evidence of increased actual risk, there is no need to avoid intercourse.
And I think this will bring us neatly back to Vincenzo's point about a apparent reduction in preterm birth during COVID. Unfortunately, it's going to be very difficult to get high quality data of actually what people were doing or what women and families were doing in terms of diet and activity, dare I say sexual and various others. But this case, this kind of like natural experiment that we are all witnessing, if true, is going to open such a huge avenues for research and just reinforce how multifactorial this is going to be, because again, it is very unlikely that there is only one single contributing factor. It's probably the package of changes, lifestyle changes that have happened that have achieved what appears to be something absolutely extraordinary.
Professor Dreykoot, do you have a comment?
I think, yeah, I mean, I agree with everyone else. I mean, golly, I've not got much to add in addition to everyone else, except to underline the ambition to understand what happened during the pandemic. What was it about the pandemic that reduced preterm birth rates? If we can understand that, then maybe we can harness that for care going forward.
Professor Dreykoot, some people were asking about the availability of the QIP application. I think Professor Al-Fattah said this, or maybe you have said it, that it is available on the app stores. Is that right?
Yeah, Android, Apple, yeah, whichever one is free, and
please just download it now.
everyone is showing they've got it, so it's a really useful thing, and I think it's going to be part of our future. We are going to be using technology to help us in ways we didn't before.
Another question for the whole panel, actually. I think it's also important, we didn't discuss it a lot. Is there a way to stop preterm labor once it's there? And what's really the definition between, or the differentiation between threatened preterm labor and preterm labor? I mean, how can you say that this woman is in threatened preterm labor and the other woman is in preterm labor? And if it is threatened, what would you do? And if it is preterm labor, what would you do? I think also this is something that we could all, or at least the panel, would give a hint on. We'll start also by Zarko, please.
Threatened preterm labor that doesn't end up in preterm labor is a polite word for doctor's mistake or our inability to diagnose preterm labor. We just have to accept that we are not very good at it, and we need help, and a combination of and to continue to rely on a speculum examination, vaginal examination, and clinical science is not going to get us very far. Transvaginal scanning and fetal fibronectin are a step in the right direction, but we probably need more. The reason why we need that more, and I don't think that it is appropriate anymore to diagnose preterm birth on clinical science alone. It was just about okay 10 years ago when we didn't have quite aggressive treatments, but now, particularly 30 weeks, you're talking about antenatal corticosteroids, magnesium sulfate intravenously, in utero transfers. So implications of false positive results are absolutely phenomenal. And all studies are consistent that we have basically, at best, only 20% of women, well, maximum 20% of women that we serious, clever clinicians label as imminent preterm birth. When you put them on placebo, nothing happens. So we have a long way to go to improve on that. And we just need to realize how much harm are we causing by labeling women in threatened preterm labor just because they have a little bit of uterine activity.
So I think one of the biggest problems in preterm birth management is the risk of overtreatment.
Completely agree.
And you know, look at steroids. Steroids are not without consequence. Absolutely. So let's use them where we need to use them, but let's not just splash them around everywhere. You know, there are good data now showing that it's not good for you in later life, but it's also definitely not good for you. You know, multiple courses of steroids are associated with increased risk of cerebral palsy. So for me, Mohammed, coming back to your question, the first thing we need to get right is the diagnosis of preterm labor. And although Zarko said, okay, yeah, it's still not perfect, if we could persuade people to use ultrasound and or fetal fibronectin, that would be a fantastic way forward. So I say, first of all, start with the diagnosis. Secondly, then treat carefully. But everyone has to start using scan and fetal fibronectin to make the diagnosis. That's the first step.
You're so right, Tim. I think it's really important also to recognise that sometimes it's better for that baby to be out of that nasty microbial soup which they're swimming around in. And, you know, sometimes I will talk to the neonatologists and say, look, I've got a woman, you know, I think she's going to develop a fever, CRP is rising, I want to deliver her, are you happy? And they say, please, we'd love that baby to be in our neonatal intensive care unit so we can treat the baby, we can give the baby antibiotics, and we just need to be bold in some way and decide to jump in. But we don't yet have good enough data. Maybe amniocentesis is the way forward. I'd be really interested. We don't do a lot of that in the UK. I'd be really interested to find out what Vincenzo would say of that, whether they use it and how he finds it, because we do need to find out what is happening in the intrauterine environment, and whether we can, you know, potentially give long-term antibiotics intraamniotically. Is that something we should be thinking about?
We don't use amniocentesis that much. Other centers in the US too. I think that's most research. But you said it already. I shared my screen before. You need to use cervical length, and as people say, 50% or more of these women have a long cervix and they don't deliver preterm. So you don't do anything iatrogenic. Only a few need to be treated because they have a short cervix. On the infection, I think we need a lot more research. Roberto Romero published, some data on treating women with a positive amnio with antibiotics. If you look at the data, really, those were women that had mostly inflammation intrauterine, and that may be more treatable. I'm very afraid of putting women, not only babies, at arm if you have a positive, positive bacteria in the amniotic fluid, and you let them continue the pregnancy. As you say, people should be delivered if they're infected intrauterine.
Yeah.
What has certainly focused our mind is this issue of magnesium sulfate, and I would just be interested to hear in Egypt what happens in a unit that do not have access to transvaginal ultrasound and fetal fibronectin, which I assume is majority of public health hospitals. So if a woman is diagnosed on a clinical examination at 30 weeks with a threatened preterm labor, presumably she's put on intravenous magnesium sulfate, yes?
No. We would give corticosteroids and we would put the patient under observation. And if she's progressing into preterm labor, we would give magnesium sulfate. So this is the problem, is that we have vaginal ultrasound almost in every unit. Vaginal ultrasound, at least in every hospital, it is available. So we do vaginal ultrasound. Fetal fibronectin is not available in every unit. So if the cervix is dilated or dilating, then we would give magnesium sulfate. But
so steroids are considered kind of like easy picking. That can be kind of given to everybody, and magnesium to only selected ones.
Actually, this was one of the questions I was going to ask you. When and if you give routinely magnesium sulfate, and at which age, and if you do and the patient, for example, doesn't go into labor, would you repeat it again or not? I think this is also a good question. It has been asked by the audience, and I like also to know, what do you do or what do you think?
Who is going to start? Vincenzo?
Vincenzo?
Sorry, can you say the question again?
The question is, what about magnesium sulfate? I mean, it is now established that it should be given as brain protection for every severely premature baby who is going to be delivered. But transferring that into actual life, I mean, when would you give it to which woman? And if you give it and the patient doesn't go into labor, what would you do? I mean, contraction stopped, or the patient is going home and she's coming back again in 2 weeks. Would that mean that you have to give her again magnesium sulfate? I mean, what's the standard in doing or giving magnesium sulfate in case of preterm labor? Because this is actually 2 questions from the audience.
So I leave the magnesium sulfate kind of on my hand because we were, on my skin, because we were part of the BEAM trial, Dwight Rouse, New England Journal. And so I'm very familiar with that and the natural data. First of all, the point I want to make is that we're all using it around the world because of meta-analysis data. People put down meta-analysis all the time, and we're doing lots of stuff because of meta-analysis. And even Dwight Rouse, who always says at the Green Journal, he doesn't like meta-analysis. He talks about magnesium sulfate and the evidence. It's not from one trial, not from the BEAM trial, but it's from meta-analysis, because that's the only way when you get 5 trials together that you get cerebral palsy to decrease. So that's one thing I wanted to state. The other thing is that the data seems to be, at least the US data, that you need to have magnesium on around the time of delivery, obviously. So we do repeat it at times. If somebody rupture membranes comes in, she seems like she's contracting, you put them on magnesium, she stops, she's in the hospital for a week from 29 to 30, then she's 4 centimeters, she goes to labor and delivering labor, and then we're restarted. The dose is another issue. Some people use 1 versus 2. Some people use a bigger loading dose for 4 versus 6. So you have to be careful, on renal function and how the magnesium is secreted. But going back to Egypt and other countries, I've been traveling the world like many of you. People use transvaginal ultrasound everywhere. People have ultrasounds, it's donated in everywhere. So I wouldn't say we don't have this, therefore we cannot do that. A lot of this quote unquote technology, we've talked about omega-3s and aspirins and progesterones are fairly available, and many of them fairly cheap. So I think we should get organized more than finding, alternatives that may not be as good, because when we do that, then we compromise the patient.
So
I can tell you
to build on that, I mean, in the UK, we would use Magsolf, exactly the same dose as eclampsia, every 30 weeks gestation and under. Now, I think the Canadians is 32 weeks, but the UK is 30 weeks and less. And certainly in our unit, we would start Magsolf in anyone we anticipated delivery in the next 12 hours. Now, if they don't labour, stop it, that's fine. If they come back in 2 weeks, they're probably past 30 weeks anyway. But magnesium is pretty easy going compared to any other drugs we use. So the key issue is the emergency ones. Can you, how long, you get some benefit after 2 hours by all accounts. So if you can get 2 hours of magnesium in, just do it. It's pretty easy.
And in terms of implementation, I can tell you how we did it in Liverpool, because we also had apparent reluctance to use diagnostic criteria, although we were available. It was really, really difficult to understand the reluctance to use vaginal ultrasound and fetal fibronectin, although it was available, particularly over weekend and nights. So what we then said is that if you have such a clinical concern that you would put tocolysis on and you would give steroids, then you need to give magnesium sulfate. Now, if you then treat these three as a package, then all of a sudden people so dislike putting intravenous magnesium sulfate that it almost forces them to actually use transvaginal scan or fetal fibronectin, which then in turn reduces significantly the use of tocolysis of steroids, because you actually then have a reduction in false positives. So what I would suggest to you that there is a merit if kind of treating tocolysis, steroids, and magnesium sulfate, certainly before 32 weeks, as a kind of like package of care in women who are threatened to deliver preterm, which then puts onus on a clinician to basically make a diagnosis much more stringently than just say, oh, I think she's a little bit contracting, let's give her steroids, and steroids and tocolysis being given like Smarties. And then we have consistently 90% of women antenatally given steroids actually deliver baby at term.
Another question is that what kind of tocolysis that we use? I mean, is there a standard tocolytic treatment for women for the 48 hours till we give the corticosteroid? Or is there a better drug, nifedipine? I mean, is there a certain protocol for tocolysis that should be used in all cases? Or is there a different medication that can be used in different gestational ages, for example, or in different conditions? Actually, this is the last two questions from the audience. So I would start again by Professor Abdelfatah. What do you think?
Again, depends on what's available. And in the UK, I've been for some time using atosiban, which works well. It's quite an expensive drug, so may not be applicable for everywhere. But again, it's always cost-benefit ratio, and the cost of looking after a preterm baby in an neonatal unit in intensive care is massive. So even if the atosiban is expensive as a drug, if it's going to reduce the cost by, if you balance the cost of the care of the baby in the neonatal unit, then it is justified. Atosiban may not be available everywhere, and depends on availability. I don't think there is one tocolytic drug is considered the best option. Nifedipine works well, and atosiban works well. I think the most important thing is just to be aware of the reason of using tocolysis. So the reason for using tocolysis is, it should be used if someone is in real threatened preterm labor, not just a bit of pain. And the purpose is to prolong the pregnancy, to allow for steroids to be given, magnesium sulfate to be given, and transfer to another unit for the neonatal facilities. So again, whichever is available, I don't think any particular tocolytic is really clearly the best one.
And I'm building on that. I mean, Sharif and I are in the same department. So, you know, one of the potential theoretical risks of using Magsolf is, you know, big hypotension episodes if you use nifedipine and Magsolf together. They're both calcium channel blockers. Is that a useful thing to do? Is it safer to use an alternative if you're going to use Magsolf? So for us, yeah, we use Tozoban because then there is no risk of double calcium channel blocker effect.
Professor Brigala, what do you think?
We use indomethacin for 48 hours, especially less than 30 weeks. If you look at, it's the only one really that has been shown to, you know, kind of as the best data, even if it's limited. And we do use nifedipine as well.
You don't have atosiban?
Atosiban we don't have, unfortunately, because of the Romero study and the FDA story, you all know.
Okay.
My understanding is that NICE have kind of come down on cost effectiveness with nifedipine as a primary tocolysis. I think I'm right in saying that current recommendation is that this is kind of like a first line treatment. I agree that there are theoretical concerns about hypotension, but my understanding is that virtually all of them have been reported in twins rather than singletons, and we have been using nifedipine with magnesium sulfate, and we haven't had in a dose of 1 gram per hour in preeclampsia dose, we haven't actually experienced that. I think that although this risk has been described, also it has been described in twins and also in the context of preeclampsia, and we know that the whole circulation and whole issue with distribution of drug in preeclampsia patients, it's completely kind of like off the wall and not necessarily applicable to what are essentially otherwise healthy women in a threatened preterm labor. But yes, it is for 48 hours almost that doesn't matter. And I completely agree with Vincenzo. I think that indomethacin is absolutely phenomenal tocolysis and particularly for 48 hours. Again, there has been safety issue with fetuses, you know, kind of oligohydramnios and kidney issues and stuff like that. But I think for 48 hours, I completely agree that the evidence is really, really strong in favor of this, particularly for early gestation.
I would agree with that. I think indomethacin, especially in the early third trimester, actually is much better than anything else. And I would agree with you and with Professor Brigala that anywhere between 26 to 30 weeks, I think 32 weeks even, I think indomethacin would be the first choice. And after that, other, medications can be implemented too. There are several questions about magnesium sulfate.
I just wanted to answer about the tocolytic. I think it's worth bearing in mind that actually we probably should be using a drug that's licensed for the indication in pregnancy. I think it's very hard. These drugs are expensive, and manufacturing them and testing them out, pharmaceutical industry testing out, is really, really challenging. And I think I'm right in saying that Tozoban definitely has a license for this use, and other drugs don't. Of course, testing out these drugs is really difficult if we are not going to want to use something cheaper. So I do feel sometimes quite poorly for the pharmaceutical industry that are desperately trying to manufacture drugs that we don't want to use.
Okay, back to the question about magnesium
just to build on that from Anna. If we were cardiologists use drugs just because they're expensive. They're reassuringly expensive. That's how cardiologists choose drugs. So I agree with Anna that where a licensed drug exists, we should use it and not have too many qualms about it.
Sorry, can I just interrupt a bit. Just Vincenzo would like to leave. So just want to say thank you very much, Vince, and your contribution was amazing. Thank you very much.
Thanks, everyone. Thanks for having me. See you in Egypt soon, hopefully.
Right.
Thank you
Bye-bye.
very much, Professor Bergella. I think we have lots of questions, but I think we cannot go on forever. And I leave the decision to Professor Nouri and Professor Mumtaz. But thank you very much, Professor Bergella. It was really amazing. And thanks, Professor Mumtaz.
Thank
What
you.
do you think? Yeah.
I think really there are many questions actually we haven't answered, but I think really the discussion today really was very interesting, and thank you very much for every speaker for giving us their time late actually this evening. So thank you very much, and we would love to see you again very soon. I'll leave this to Professor Salam to conclude the webinar.
Thank you very much. I also want to join you in thanking the speakers and for their contribution, for taking up of their time to share with us their experience, vast experience and great knowledge. If Professor Draycott wants to say something about the prompt training project, or maybe we can have another whole webinar for the prompt. I will explain to our fellows and members who already know a lot about it. Thank you all very much, and thank you, Professor Draycott. Thank you, Professor David. Thank you, Professor Alferevich, for all your time, and many thanks for Sharif Al-Fattah, who was really who has made all these efforts to bring our world-class speakers tonight. We don't want to stay a lot and take more of your time. And finally, I would like to thank my, Professor Amr Nouri and Professor Mumtaz, and maybe Sharif Al-Fattah wants to say something.
Yeah, it's just when Professor Salam asked me some time ago if to organize this webinar, I told him, I promise you I will get you the best speakers. And I did. Thank you very much for all the speakers.
I think you did, and thank you very much.
It was amazing. Thank you very much.
Thank you, everybody, for the panel. Beautiful. I'd like to thank Merck also for hosting this webinar. And I'd like to thank the audience. Actually, they have been very interactive. We have tons of questions that we didn't answer. And I hope that the speakers can get to the questions and answer them later on. Thank you very much, Professor Salam, for asking
Thank
to
you very much. Thank you. I think we reached more than 2,000 registrations, actually. There are about 900 who have joined by online, but there is also the Facebook also audience. Thank you very much. It was a great pleasure. And as we say in French, à la prochaine. I'm a bit of a frog, as you probably know. Okay, so thank you very much, and good night to everybody, and thank you very much, Merck, and thank you very much, Booster Bees, and see you again, hopefully in person in Egypt, in Cairo, but more importantly in Alexandria. And thank you very much.
Thank you.
Bye-bye, everybody.
Bye.
Bye-bye.
Thank you all.
Bye-bye, Sharif. Thank you.
Bye.
Bye.
Bye-bye. Bye-bye, Dr. Anna, Dr. David. All right.
Oh, pleasure. Call me Anna.
I call you Anna, and you call me
Yeah, no, call me Anna.